Good morning and welcome to the 25th meeting of the Health and Sport Committee in 2020. We have received apologies this morning from Alex Colhan. We have a busy agenda today. The first item on our agenda is an evidence session with NHS 24 as part of the committee's ongoing scrutiny of NHS health boards and special health boards. I would like to welcome to the committee this morning Dr. Martin Sheen, Chair of NHS 24, along with Angelina Foster, Chief Executive, Stephanie Phillips, Director of Service Delivery, and Dr. Laura Lyon, Medical Director. Good morning to you all and welcome to this meeting of the committee. We are going to ask questions in a pre-arranged order as works best in a virtual meeting of this kind. I will start first with the first set of questions before asking each member in turn to ask questions. I will then invite witnesses to respond. I'll generally invite one witness from NHS 24. Clearly, if others wish to offer an additional response, then please indicate who and are in the chat box. Can we then start with looking at the position of NHS 24 in its position in relation to NHS generally? Clearly, your position is one where you are a national service, you deal with a broad range of health conditions. You are dealing with, I guess, pretty much every other part of the NHS one way or another. I wonder if witnesses would agree with the proposition that NHS 24 sits in a useful surveillance position for the rest of the NHS. And if so, in what ways is this true and to what extent is that utilised? And how do you feed intelligence or views to the rest of the NHS in Scotland? I wonder if we could start with Dr. Martin Sheen.
Good morning, Convener, and thank you for the invitation to attend this meeting this morning. NHS 24 does indeed, Convener, have a very unique position to play in the wider system of the NHS. We are very data-rich in that we serve the population of Scotland. We have a collection of data which is used by Public Health Scotland to enable them to analyse and inform health services and service delivery going forward. So from that point of view, while we are unique, and we have indeed become, if you like, more unique in the last 6 or 9 months with the data we've collected due to the COVID pandemic, we certainly do have information which has enabled the NHS and Scottish Government officials to analyse and inform forward planning.
Thank you very much. And I wonder if Angelina Foster would want to add anything in terms of the interrelationship between the intelligence you provide and the directions or advice you receive from elsewhere in the NHS. Make best use of that.
Absolutely. Thank you. Thank you, Convener. So I think I may start by saying that one of the things that characterises NHS 24, it's the range of channels through which we deliver our services, principally through telephone and a number of digital sources. And for that reason, that means that, as my chair has already explained, we are very data rich because so much of our interactions with our callers and our patients are recorded one way or another. So quickly, 2 examples of each of those services. So our 111 service would be a strong example of our telephony-based services, and NHS Inform, very strong example of our digital services. Both are now being used to feed other parts of the wider system from an intelligence perspective, exactly as you have suggested, Convener. So let me try and give a couple of examples. For wholly understandable reasons, much of the public focus in the public narrative, we might say, around the pandemic is on the requirements for intensive care capacity, and we all understand why that is a key focus. However, because of where in a patient's journey NHS 24's service comes in other words, much earlier than that, our data acts as a lead indicator. So, for example, for the prediction purposes of a second or a third wave, then our service demand patterns will begin to show that some weeks ahead of an ICU peak. So that's a volume indicator. Equally importantly, at the level of geography, then our call patterns, which we share with Public Health Scotland, amongst others, and the committee may want to hear from our medical director, Dr. Laura Lyon, who leads on that engagement with our public health professionals for a little more detail. But my point at the moment is that we can use our data to help public health colleagues anticipate and predict very localised outbreaks because of our the nature of our work. So those are just two examples. But if you would like to hear from Dr. Ryan, then I'm sure she'd be happy to expand on that.
Thank you very much. Laura
Lyon. Thank you, Convener. As Angelina has outlined, we have worked very closely with Public Health Scotland over the course of the COVID pandemic. Prior to that, NHS 24 intelligence and data went to the Unscheduled Care Data Mart, so data sharing is not something new to us. We use it for the purposes of live service monitoring, planning going forward, and also future planning in terms of our strategic intent. And one example of that would be our mental health provision, because we have noticed over the course of the pandemic that quite rightly we expanded our mental health provision. But that is based on intelligence that we had to make it clear that there was a mental health demand. In terms of our data about equality and diversity, we became aware that we had to make information and guidance and indeed our 111 service accessible, and as we have done that, we have developed dashboards for data that allow us to monitor and to report on that intelligence, and that too, that digital information as well as our 111 services is shared with Public Health Scotland to give a full and in the round gathering of data and sharing of intelligence with narrative.
Thank you very much. And I call on David Stewart.
Thank you, Convener, and good morning to the witnesses. I have a number of questions about evaluation of your service. My first question is, what should the public expect from NHS 24?
Angelina Foster.
Thank you. What they should expect is a wholly accessible, clear, reliable, trustworthy, clinically sound and clinically assured service. And on the point of evaluation, which clearly underpins your area of interest, then I would say we evaluate our services at a number of different levels. So let me firstly explain that structured evaluation is an inbuilt part of all of our service development process. So perhaps most useful to illustrate it with an example, we launched a new mental health service in March 2019. And after 6 months of operation of that service, there was a structured evaluation. I should say, more often than not, the evaluation is done by an external party for reasons of objectivity, as you may expect. And the expansion of that service, which has since happened, would not have happened had that evaluation not demonstrated such strong appreciation, value, etc., in the feedback and the evaluation. So it's absolutely inbuilt and very, very structured. I would say, though, evaluation also works at a more organic level, but I would suggest that's every bit as important, and that's the day-to-day interactions that we have with our public, our patients, our partners in the delivery pathway, and that's live mini evaluations, we might say, that we listen to extremely carefully and then aggregate to hear what the thematic messages might be. I would say the other important part of our evaluation work is that because we deliver through a number of different channels, then we may have the same service but available to the public through different routes, and we also very carefully analyse the effectiveness, the value to the public of the different routes. So again, a specific example there would be our breathing space service, which is a compassionate listening and advice service for people experiencing low mood and anxiety. That is available both through telephone and web chat. And my colleague Stephanie Phillips, our Director of Service Delivery, may wish to expand a little more on this if this example is of interest to you. But we see different demographics in those two channels and also different levels of need coming through those different channels. So there's an important point that we are learning through this evaluation of the channels around the potentially more accessible route for delivery of service for certain subgroups in the population. So that's a level of nuancing that we're working on almost constantly. I'll pause there and check if that was of help, and if you would like the web chat versus telephone evaluation expanded by my colleague.
Thank you for that. That was very helpful. And you've touched on my next question, but perhaps just you give me a few more examples. Are you basically saying then that the external evaluation helps your organisation learn and improves your organisation? Is that a fair summary of your comments?
It's a perfect summary. Perfect summary. Thank you. Yes, absolutely. And we have a small team in the organisation who are engaged in quality improvement work. We have a patient experience team who draw proactively and responsively on feedback from our users, and all that feeds in to our improvement thinking.
David Stewart.
Thank you, Kavir. Can I move on to some other questions around evaluation? Can I take you back to the early days of NHS 24? As you were aware, there was some criticism at that stage for delays in answering calls and staffing problems. Has this been fully resolved now?
Thank you. The very high level answer is yes. Those difficulties, I should point out, precede the tenure of any of the colleagues with the committee this morning, but we are aware of that background. My understanding, though, is that those were very much relating to the setup of this, what was at the time a radical new service model. So yes, those issues have all been addressed. What I would observe, though, is that a core challenge for all contact centre-based organisations is what one in our language is described as the call arrival patterns, because clearly there are peaks and troughs. So the public will find if they are calling at a time when the service is under less pressure, then clearly they will wait, often simply a matter of seconds, to get through to us. If it's a period of extremely high demand, then they may have to wait a few minutes. We do try to manage that in real time with the recording that callers hear. I'm referring here to the 111 service in particular. They hear a message that gives an indication of how long they may have to wait, and then callers can make a decision on their own behalf whether they would like to call back for less busy time. So we try to empower the caller to make a judgment on their own behalf and to help them have the best experience in that.
David Stewart.
Thank you for that. My final question, Convener, then is, what assessment have you made of the benefits of NHS 24 to the rest of the health and social care service? And for the average patient, which is obviously a difficult concept to quantify, is the average patient aware of the sort of what I would call the architecture of the NHS? When to use the GP by phone, when to go to A&E? Because you'll be aware, particularly from, I think, England, there was the problem that a small minority of people were using A&E disproportionately, and I know there's been some studies on this. Is this the same sort of issue that you face in NHS 24?
Thank you. It is such a good question, and I would have to say I think you have put your finger on a real issue for us. I think it is a very big and arguably unfair ask on the public to work out exactly the most appropriate access route for them to choose across the entire health and care system. So I think the onus should be on the different providers, including NHS 24, to make those access routes, firstly, as clear and simple as possible, but secondly, the quality of public communication and explanation, I believe, is for us as a system to get as good as possible, rather than expect the public to navigate an inherently complex set of choices. So a key role for NHS 24, therefore, is in fact that guidance through the system role. So NHS Inform is used by many citizens to help them work out where best to access services. So I would say that is a key role that we play. What I would ask the committee to appreciate is that in normal times, then services are in development, and it may well be that the correct access route for the public is changing as services are brought on stream. That is even more so the case during this pandemic. I would illustrate that by saying that before the pandemic, 90% of NHS 24's 111 caseload came to us in the out of hours period, and that was as it was designed. Just as you alluded to in your question, GPs are the principal port of call for citizens in the in-hours period. I would, in parenthesis, point out that the out-of-hours period accounts for 71% of the week, so it is a chunk of the week. But from the 23rd of March, and in direct response to the pandemic, NHS 24 has also been the front door or COVID-specific assessment in and out of hours. That was to give the public, so absolutely to your question, give the public an unmissably clear and very accessible route into COVID clinical assessment. It also was a way, back to the earlier part of your question, it was a way of taking pressure off the wider primary care system by drawing COVID clinical assessment towards the national service and, as I say, taking pressure off that system. The other thing that NHS 24 has done as a response to the pandemic, in similar vein and to your question, is the standing up of a non-clinical helpline. So that is an 0800 number, and that deals nationally from 8 o'clock in the morning to 10 p.m, 7 days a week. So it's not 24/7, but it's nonetheless long opening hours. That is dealing with general inquiries in relation to COVID. I am conscious I haven't yet picked up the detail of your question around evaluation of the benefits to the service. I'm happy to do so, but I'm conscious I've spoken for some length. So I'm going to pause to check that my comments have been helpful, and then I will resume to pick up your question about how do we measure the benefits to the wider system.
Yeah, thank you. That's To you, Convener. That's a very full answer, and perhaps you could drop a line to the committee about this. I'm conscious of time. Other members wish to intervene. Thank you.
Will do. Thank you very much. And I call David Torrance.
Thank you, Convener. Good morning to witnesses. My questions are around performance targets, and you answered a bit by a previous committee member. But NHS 24 provided the committee with a summary of performance against its targets. This shows they are meeting most of their targets in the area of poorest performance is a relation of time taken to answer calls. Can you expand on what reasons are underpinning these missed targets?
Angelina.
Thank you. With pleasure. And I will start this answer, but I think the committee may find it helpful to hear from my Director of Service Delivery, Stephanie Phillips. However, let me start by reassuring the committee that all of our clinical targets are not only met but exceeded. So I think that's an important patient safety observation to begin with. You are absolutely right. The targets that we have missed relate to time to answer. There's an important patient priority that sits underneath that. And this also allows me to refer back to the earlier discussion about evaluation. We talk the whole time to our user groups around what is important to them in our services, and an important piece of research that we did, I think a little over a year ago now, possibly 18 months, was to ask our callers, what is more important to you? To have the phone answered extremely rapidly in seconds, or once you get through, would you prefer to be dealt with in one single transaction? So please bear with me whilst I explain that in order to answer the phone in seconds, the whole time, regardless of high levels of demand, that can of course be done. That would require the service to quickly deal with the immediately presenting need and put that patient in a queue or a callback. And that was the key feature of the previous operational model. So rapid response in a queue for a prioritised callback. Strong message from our public engagement was that the unequivocal preference from our patients was to be dealt with without the need for a callback. And in our dialogue with them, we explained the trade-off between speed of answering and not requiring a callback. And they absolutely clearly said, we would rather wait a little longer for access to the service in order that we are dealt with in one transaction. So that's, I think, an important underpinning thing. And for that reason, that target is under review between ourselves and the sponsor department and government in order to try to perhaps identify a target that more reflects what I have just tried to explain there.
Thank you very much. Stephanie Phillips.
Thank you. Yes, I think just picking up on the points Angelina's made there, I think we do recognise that the average time to answer is a key measure. But I think the challenges for us in recent months have obviously been quite a sharp increase in call volumes, which obviously has a direct impact on our capacity requirements as an organisation. And as Angelina said, that was very much driven by a discernible shift as we took on that role as the national access route into the COVID pathway. So we saw a shift from a predominantly out of hours provision to increased in hours activity. And that actually meant that we've had to shift our workforce and our capacity to be able to accommodate that. So again, that's a factor I think that is also part of the consideration. We do manage that real time, as Angelina has said, so we do ensure that we are making use of upfront messaging. So when the call is answered, callers will be advised how long they may wait. and they can then, in fact, they'll have an indication of how long it will be before we answer the phone. And we also try and encourage people to take decisions at that point as well, whether or not they could actually access information through NHS Inform, for instance, and that links to where callers may choose to go and access that route first. So we do try and keep the public informed and callers informed at all times when we're actually bringing them into the service. But clearly that remains a challenge. I think one of the important things that we have seen as we've moved towards this new model, and we've really tried to focus in on the overall patient journey time, is we've seen a significant reduction in the total time people are engaging with NHS 24. So we're not putting anyone in a queue or minimal numbers of people in a queue, and we're actually managing that call in one single transaction over 90% of the time now, which is a significant shift from where we were previously.
David Thomas.
Thank you, Convener. Data shows that between 8 and 9% of calls are abandoned altogether. What happens to abandoned calls, and can you call them back?
Stephanie Phillips.
So I think probably one of the things to say up front is that abandonment rate is not always reflective of a bad thing. As I said, the first message that someone will hear when they phone NHS 24 is, if it is a life-threatening emergency, you should put the phone down and dial 999. So we do try and encourage people to come into the emergency services appropriately. We are not an emergency service, and I think that's an important point to make as well. We also, as I've said, where callers are coming in traditionally during the in-hours period, they will hear a message that will encourage them to think about contacting their GP in hours, if that's a more appropriate route in. And indeed, we also try and route people towards NHS Inform again. So it's about choices that people will make at the start of that call. Abandonment rate is directly linked to levels of demand as well. Without getting too technical, there is a correlation between these things. So clearly, obviously, at times of acute system pressure where callers are waiting longer to get in, they may choose to abandon within that. But we are able to monitor, and we do monitor the kind of volumes of people who try again. So we are able to track and analyse that information. So we can be assured, I think, that there's a degree of safety, so we know people have attempted to recall. We can't call them back because we've not got a connection with them, so we haven't got a number to call them back on, but we are able to track whether or not they have attempted to come back in to the service. But I think we monitor abandonment rate because it's a fairly standard measure of call centre performance, contact centre performance. But we are cognizant of the fact that it's not always a bad thing that somebody has abandoned because they've maybe made the right choice rather than coming in and hanging on for us.
David Thomas.
Convener, I have no further questions.
Thank you very much. And I'll call George Adam.
Thank you, Convener, and good morning to everyone. I'd like to ask about staffing, and the recent NHS 24's most recent review said the detailed staff attendance was at 92.6% as opposed to a target of 95%. Now that's in your report, but then in paperwork you provided to the committee, we've actually seen that in the previous quarters in 2019 that had fallen to below the target again. In quarter two, it was 2020, it's been 93.1%. Can you possibly explain to me what's that all about?
Angelina Foster.
Thank you. And I would like to say up front that our attendance levels are not as good as they need to be, and it is a key priority both for the board and for our executive management colleagues. There are a couple of historic systemic structural issues in there, which I may suggest that Stephanie Phillips explains to you, but let me say in a more up-to-date sense exactly what we're doing at the moment. We have a very detailed action plan around that, which has been constructed in collaboration with our staff side, because clearly our staff side need to work well with management in an area such as this. And our partnership colleagues on staff side are wholly supportive of the actions that we're taking. Indeed, we invited a critique of that attendance management action plan by our internal auditors, just to put a bit of stretch into it, and they gave us some very helpful comments, and so we further strengthened that plan. We've also taken very seriously the fact that attendance management isn't all about the rulebook of HR. It's very much an issue of staff well-being and support as well. A contact centre environment can be a very pressurised one, so we need to both be very, very supportive of our staff as well as firm where appropriate. But there are two things that we have changed in the last year or so in order to address the semi-structural issues that we believe were contributing to this. And with the convener's permission, I may suggest that Jeff Phillips explains those two things to you, because they are pretty fundamental to our work. I would, however, point out that at the moment, this area is getting better, so it is moving in the right direction, and we have set a further 2% improvement target for the rest of this.
Stephanie Phillips.
Thank you. Yeah, I think important to reflect that one of the biggest challenges for us, obviously, is that we are working in primarily shift basis, and an awful lot of the shifts that our staff are working are the less favourable ones. So they're all out of hours, they're all evenings and weekends, and that is without a doubt a factor. So in listening to staff, we gained an understanding of the fact that shifts working and the shift arrangements that we had in place were quite a driver in terms of absenteeism. Also as well, I think working in a contact centre can be quite an isolating environment. You are coming in and you're plugged in, and that's your day. So I think what we also recognised was that we needed to create a sense of team working and really think how we could bring staff together to work in discernible and identifiable teams. And very much the shift review that we undertook last year, which took us 18 months to do and involved 900 staff, so quite a significant undertaking, was geared around aligning staff more closely with one another, so that we were not only able to align them with that team that they would work in, but also with their manager, and create time for that interaction and support with their manager and with their peers. So a real kind of desire and intent to create a kind of learning and working together culture in the organisation through that review and creation of discernible teams. And that includes building in protected time at the start of shifts and within their rota pattern for, as I say, development and learning and sharing and general well-being. So we have actually expressly built that into the patterns that we have in place.
Thank you, Convener. If you take on board all the challenges that you face, and this is for the Chief Executive, Angelina, if you take on board all the challenges that you've already said that you face, and the figures are struggling currently, how do you propose to deal with the added pressure? Because you're going through a major recruitment drive at the moment for the potential COVID-19 second wave. So my question would be, how are you dealing with that major recruitment wave, knowing the challenges you already face plus the extra challenge, and where are staff being recruited from?
Angelina Foster.
Thank you. So two main staff groups, I think, that would be relevant to this area of inquiry. One would be our call handling staff, and the other would be our nurses. So the answer is quite different in both groups. So for our call handling staff, the truth is that we have found it extremely easy to recruit successfully for the expansion numbers that we need. The sad truth is, I think that is a reflection of the deeply difficult labour market for the population. So, for example, there are large numbers of very, very well-skilled people with first-class customer care skills who are without a job at the moment. And so we have been the beneficiaries of those people who have themselves been the casualties of some of the economic impacts of the pandemic. So our challenge in the expansion, therefore, for call handling has less been around the recruitment itself, but there is clearly a logistical and a time pressure challenge around training those staff at the rate of knots that is required. Our recruitment of nursing has also been so far relatively successful, but that is a pressure point right across the entire health and care system, as I'm sure the committee is aware. So that we have to work harder, as it were, to find our nurse numbers. What we did do very successfully in recent months, however, where appropriate, we managed to borrow nurses from other health boards who perhaps found themselves standing down certain areas of service. So there has been good sharing of that key clinical capability across the system, and that has been a source. I should also say that we have brought into the organisation in the last few months other clinical disciplines as we have developed the service in response to the different needs of the pandemic. So there has been very good, what I might call permeability between different health boards to move our scarce clinical colleagues to exactly where they are best.
Okay, one final question well, two final questions on the points you raised. How long does it take to train the staff, and what will happen to them when the pandemic subsides, so mid to long term, and how many redeployed staff has your organisation benefited from during the pandemic?
Angelina Foster.
Could I take the what will happen question first, please? The answer there depends on which area of our service they have been recruited to work in. In some areas of our expansion, that expansion has been what we anticipate will be permanent. So, for example, the expansion to a 24/7 service of our mental health hub, that was the example I mentioned at the beginning in relation to evaluation and its role, then we anticipate that that service, let me start again, we anticipate that the population's need for that service is not going to diminish in the foreseeable future, and therefore those staff are likely to be with us post the pandemic. For some of the staff that have been very much for this immediate increase for call handling capacity, for example, then contractually a number of those staff are on temporary contracts, and they wholly understand that, and what happens to them will very much depend on where the service model and service pressures land at whatever point we as a country decide we are emerging from any final wave of the pandemic. So not possible to say with any certainty or reliability exactly what proportion of staff we will keep and which we may need to end their temporary contracts. The how long it takes to train point, again, is different according to which bit of the service they join, and I may suggest that my colleague Stephanie could give you some detail on that. What I would say is it's intensive training, and it's quality and intensive training. On the how many redeployed staff, I personally don't have that at my fingertips, but be very happy to follow up with a note to the committee in order that I don't guess that number but give you a wholly accurate figure.
That would be very helpful. Thank you very much. And Stephanie Phillips.
Yes, thank you. I think probably just up front to differentiate between what normally happens and what's been happening throughout the pandemic, because we have brought in a considerable number of additional staff into the organisation. So normally what would happen is we would have a 4-week training programme that would be a mix of 2 weeks classroom and 2 weeks supported working on what we call protected pods. So they're working on the floor, they're dealing with live calls, but they're doing that under enhanced supervision. So that is because that reflects the need for these call handlers and clinicians to be able to deal with anything that comes into the 111 service, to be able to manage that regardless. What we have done during COVID is brought in additional capacity to provide that national pathway. So that is one single clinical pathway that we are operating. So we have condensed the training period to reflect that, and it is really just within a week that we are bringing those people in and teaching them how to use our system, but also because they're not required to deal with anything, they are just required to deal with that one pathway, are supported that.
Thank you very much. And I call Emma Harper.
Good morning to everybody. I've got a couple of questions on digital exclusion, or more positively, digital inclusion. And I can see from the submission by NHS 24 that there have been a number of ways in which existing services are being enabled online, and the role that is growing in the provision of digital services. And there's been a number of examples provided, like translators from NHS Greater Glasgow and NHS Lothian being brought in to help translate COVID public health information. And also the NHS Inform website has expanded the level of translated material on the website, and that NHS 24 has worked with the community to create a glossary of terms to be used for translation, taking account of local dialect and nuances in language. So I'm interested if there are any particular groups of people that are at risk for being excluded from digital services or any of the services, and what can be done and what is being done to help engage people that might be excluded. I'm thinking about BAME people, so the Black, Asian and minority ethnic people, but also gypsy travellers as well. So what's being done to help support people who might not necessarily have digital access?
Angelina Foster.
Thank you. We have a small but very passionate and energetic team in our organisation whose core focus is participation and equalities. So they are our key group that engage both with members of the public across all of these groups at risk of exclusion, of a range of sources of exclusion, of which digital is one. And also they engage very actively and constructively with the many representative groups of that wide range of interest groups and potentially excluded people. In the digital context specifically, then we have at the moment, I think at today's date, we have our online NHS Inform content available on 11 minority languages, many of which pick up that BAME grouping that your question referred to. In addition to those 11 minority languages, also British Sign Language, Easy Read and audio, so very much engaged in addressing exclusion through disability as well as potentially race and language. The team that I refer to are also actively engaged with our Gypsy traveller community and their representative groups, so they are absolutely within our range of view as well. I think whilst we do work extremely hard around inclusion and hard to close down any risks of digital exclusion, I would have to say that I think some of the root cause of digital exclusion is not for my organisation to attempt to fix single-handedly. In other words, it's a national infrastructure piece around connectivity and so forth, and it runs in my mind that the most recent programme for government did contain a very clear commitment to address that at that level of national infrastructure. What I would like to say as well, though, is that I think in the context of equalities, digital itself can address other forms of inequality. So, for example, for an individual for whom travelling to a clinical site for a consultation may pose them either financial hardship if the travel costs are material to them, or if they have a disability and it is a major issue to have to take public transport, etc., a clinical site for a consultation, then the offer of a digital route is tremendously welcome and could well be the access to that advice that they may otherwise not have been able to secure for themselves. The other slightly subtler but very, very discernible to us area there is that there are forms of emotional and psychological exclusion where for some areas of need, particularly in the area of mental health, for some members of the population, they feel unable or at best disinclined to articulate their issues face-to-face or even by telephone. However, when offered a digital channel, that is the access route through which they can reach out for the help and support that they need. So it's an interesting mixture of both risk and opportunity that is offered by digital channels, I think.
Laura Lyon. Can we have the same, please, for Dr. Laura Lyon? Yeah. There we are.
Thank you, Convener. I wonder if it's worth in this context, in addition to what Angelina has outlined, describing benefits for all in terms of recognition of potential digital exclusion and how we respond to that and provided for it during COVID specifically. So at all times, I would say telephony remains a choice for the public. We recognise that 85% of people phone on a mobile, but the option to phone us from a landline remains. And in particular, during COVID, that option remained, even though huge volumes of the country decided to use access points through nhsinform.scot. Two other examples I would like to highlight that was digital development but benefits all patients is how we can now prescribe remotely and share the record with community pharmacy. So no matter who you are and how you access 111, your prescription can be sent by clinical email with clinical detail that the caller has shared with you to ensure and maximise safe prescribing, but also the best patient experience. I think as well we have identified groups that did not have any digital access or for one reason or another could not use the technology. And because where NHS24 is positioned in the patient journey at the very front side of that, we recognise that these people needed appropriate access to signposting around testing. So what we did in collaboration with our partners is arrange for this group who could not access signposting for testing via remote digital means. We arranged with our partners to speedily pass them down to our partners so their need could be responded to, thus not delaying them in the system either digitally or via the telephony routes normally used.
Thank you very much. Emma Harper.
Thank you for your responses. I've got another wee question about the public being involved in designing the services. I'm just wondering how how the public are engaged. And I also note that in the NHS 24 submission, it says that the NHS 24 had the opportunity to accelerate GP web services programme to increase the availability of GP practice websites to enable the local populations to access local information. Have you got any information about whether how many GP practices helped participate in NHS 24, supporting them to widen their website, I guess their website education, for instance?
Angelina Foster.
I'll start off the answer, and I will pick up how are the public involved, and I may suggest that Dr. Ryan could pick up the GP website point. So in terms of how the public are involved, then in NHS 24 we have adopted a thing called the Scottish approach to service design. That's a 4-stage process for designing service, the first of which is called discovery, which is a little bit of jargon for talking to your customers. And so that is an inbuilt part of how we would start any process of either creating a service from scratch or redesigning an existing service. We would sit down with our user groups and the public, and crucially, we would make a point of engaging both with people who use our services and, absolutely importantly, with those who do not. Because in a service design moment, it's we believe as important to listen to the people who for some reason are not yet accessing our services. An example where that good quality engagement with the public has really improved the service would be NHS Inform. In 2016, that was refreshed with very intensive public input. Before that refresh, the monthly usage, so the visits to the site of NHS Inform monthly, were very roughly 40,000 a month. After that refresh, over the following months and right up until COVID, to give you a more representative level of usage, the monthly usage was routinely hitting 4 million visits to that website every month. So with good user input, the design, the accessibility, the value, everything is improved. So that would be the specific example I would give you there. And on the GP website, perhaps Dr. Ryan?
Laura Lyon.
Thank you, Convener. This gp.scot development was about ensuring we collaborated with BMA, GP colleagues, to ensure that the front-facing element of primary care and general practice, which is recognised by the public as their front door to urgent care, gave access and choice via channels for the public to access primary care. And as we know, this supports the role of the GP as the expert medical generalist, but also the multidisciplinary team and information about that. As Angelina has described, our design is user-centred, that is citizens and patient groups, but also critically our partners and the people who deliver that care to patients. Patients want to know that their clinicians and supporting teams have been involved in design of service for them. So going back to the original question, the initial plan was to implement this in 30 practices, but we have been enabled to scale that up in COVID to 60 practices. What this specifically does is that it allows alignment and visibility to the end user or the patient, or indeed anyone using the practice on behalf of the patient, to access immediately all resources in NHS Inform, And also it's on the platform, it enables what we call near me, which is the ability to consult remotely with patients, which, as we know, when chosen by patients, is a very effective means of interacting clinically with people. I think ultimately what this comes down to is the realistic medicine approach to what is important to you. And I think we are expanding that channel choice and the demand for digital access while retaining the benefits of face-to-face for those who need it.
Emma Harper.
Thank you for those responses. I'm going to move on to some couple of questions about COVID, and I know you've described already, Angelina, about the evaluation of the service of NHS 24 service. I'm just wondering, are you seeing an increase in activity in the activity for the COVID hubs, as in, like, in more recently? Would that indicate that maybe we're looking at a second wave? Are you seeing an increase in that activity for community hubs, basically?
Angelina Foster.
So I may pass this to Dr. Ryan shortly, but what I would say is that as we have gone through this pandemic, yes, we have seen different patterns come through both our part in the patient journey and for the COVID hubs themselves. So at the moment, there is not, to my knowledge, a peak coming through the COVID hubs. But as I tried to explain earlier, as a lead indicator, then that may, our bit in the service may at some point begin to show that. And perhaps Dr. Ryan would like to expand on that as our key interface with that part of the service.
Laura Lyon.
Thank you, Convener. I think, as Angelina has described, at different parts in this pandemic, we saw demand increasing. So initially, quite understandably, when the public appetite for information, or understandably a certain amount of worry in our citizens, there were high volumes of calls. But because of the nature of those calls, we were able to give a lot of self-care advice. So that in turn meant that only sicker patients went down to the COVID hubs. We self-cared on average 25% over the course of the initial wave, but at those increased times 50% of self-care. Another recent peak in activity was the return of school children to school, and a similar pattern there where we had an increased number of calls, probably because of the attention and focus on children going back to school, and again high volumes of calls but a very high volume of self-care. Over the course of the pandemic, we have been monitoring both unscheduled care and COVID outcomes for safety reasons and also the impact on our partners, because we realise that these COVID hubs and following community assessment centres are staffed by a very precious resource, but nonetheless we need to balance that with the risk to patients. So what I would say is, in the early phases, we had an initial return to our partners of a less urgent request to phone the patient back within 4 hours. But as time went by, this began to decline and the 1 hour outcome began to increase again. Of note also was that we recorded all of the data about those patients at risk, so those in the shielding group and the flu group. In terms of the current demand and impact on COVID hubs, that is something we are working very clearly with our partners on. To give the exact detail on the volumes today, I would need to probably get back to you with a report on that. But what I can say is that one of the groups that we have seen now at this time of the year is people who are post-vaccination. And this had potential to make the COVID hubs very busy, but an evidence-based approach and working with partner experts has meant we can come up with a pragmatic approach to that group, which means we're actually supporting traffic to the COVID hub.
Very much. Emma Harper.
Thanks. That's interesting, actually, about seeing an increase in traffic due to flu vaccination, for instance, because we're going to have a massive need for more people to have flu vaccine. I'm wondering also if you've seen any trends in any particular conditions, such as a drop in calls from any particular conditions, or even conversely an increase in calls for particular conditions aside from COVID. So, for instance, are you having more calls related to mental health conditions? Are you seeing any trends? Obviously, you'll be monitoring particular trends for up increase or decreasing in particular conditions.
Laura
Thank you.
Lyon.
Thank you, convener. We have, as I discussed earlier, aligned our COVID pathway to public health data to allow the patient journey to be visualised from beginning to end. This allows then a continuous stream of data around people who are in the group that would normally get the flu vaccine, so a range of conditions, and also the shielding group. So we have been able to monitor throughput on that. What I would say is that 5% of the people who call us had COPD. So as we know, that's a group that we need to be careful about given their respiratory risk. What I would say in answer to your question about normal volumes of callers, we have consistently, as well as COVID pathway monitoring, been monitoring our unscheduled care flows. So that would be the people who phone with other reasons in the out of hours period with COVID, and constant monitoring of that has demonstrated that we have not seen any change in call pattern. For instance, we have not seen people presenting later with conditions, and the exact profile of the call reasons has pretty much remained the same. And we will expect that to continue. Obviously, we will monitor it with winter illnesses. But just to summarise, we have the data, we have flagged the COVID records, and we will keep an eye out for conditions, and that intelligence is extracted hourly to Public Health Scotland databases.
Emma Harper.
Just a final question. We are hearing about more and more people describing symptoms which are labelled as long COVID. So are those patients calling NHS 24 or are looking for info on NHS Inform, or are those patients going to their GPs?
Laura Lyon.
Yes, long COVID is a very hot topic, I suppose is one way of putting that. I feel that those patients, from what my understanding is, access services via their GP. This is one of the areas where patients have an understanding of appropriate access and who best to speak to, so that would normally go through their general practitioner. Our approach to clinical triage would assess each person according to their needs on a person-centred basis. And if it was recognised through our clinical triage that someone potentially had symptoms that were persistent but not requiring referral at that time, they would be redirected to their primary care physician who knows them best and has their medical records.
Thank you very much. And I now call on Sandra White.
Thank you very much, convener, and good morning, panel. Thank you very much for your submission. I want to follow on some of the questions that Emma had asked. Now, we know that the government is monitoring 4 areas, harm, with the patients or the general public from COVID-19, and 2 of those areas are direct health impacts and indirect health impacts. Now, you answered Emma by basically mentioning the COVID symptoms, but I'm more interested in directing people to like dental services, etc., because GP, etc., simply because of the lockdown. So one of the questions I wanted to ask, I think Emma did touch on that, has NHS 24 seen the indirect health impact of COVID-19 and lockdown, and where is it most noticeable if you have seen that? I know Emma mentioned mental health, but is there any other, impact that has had a negative impact on people's health where you've got to direct them elsewhere?
Angelina Foster.
Thank you. Yes, principally in mental health. So, as the committee may expect, much higher levels of anxiety in the population. Root cause, a mixture of economic worries through furlough or job loss, family and relationship stresses and strains, if not triggered by lockdown, then certainly exacerbated by lockdown. A higher level than usual, I am very sorry to say, of people with suicidal thoughts. So that's a very discernible and alarming trend. So, the short comment there would be a range of internal well-being issues that are very starkly coming through in our work. You are quite right to mention dental services also. A key part of our service is the Scottish Emergency Dental Service, which runs as part of our out of hours. It's one of the options through our 111 service out of hours. Because of the standing down for safety reasons of community dentistry, then we rapidly changed our working model there, and we benefited from some dentists who were not working, who, and this is a good opportunity for me to give credit and say thank you, they worked for NHS 24 on a pro bono basis, so public thanks to them, but that allowed us to offer an enhanced service through our digital and telephony routes through the additional workforce there. So that we feel has been a good model, and indeed, because it was so well received by the public and the clinicians themselves, we are now running that to evaluate it as a possible longer term service change. I'm not sure if any of my other colleagues want, I think Dr. Ryan would like to contribute to the wider COVID harms point as well.
Thank you, Convener. If I could just build on Angelina's point about dental, and an earlier point I made about expanding our service in response to user feedback and working with our partners in the community, we have expanded prescribing in the dental group. So not only do they get that extra level of triage, while they were not able to work for safety reasons in the community, we also made their patient experience and patient journey quicker through the system in general, because the dentists were able to prescribe in NHS 24. And also the other benefit it had was that the dental staff were able to directly refer to advanced services within our hospital system. So, for instance, to maxillofacial services. So the addition of the dental staff expanded our advanced clinical support team in NHS 24. It advanced prescribing and it improved the patient journey.
Thank you. Could I just perhaps ask Dr. Ryan just another question? We talked about dental services, and Emma had mentioned patients with COPD. Could you tell us, has there been an increase in more severely ill patients presenting to the service as well? COVID-19.
Thank you. And MSP White has just caveated that with COVID-19. So what I would say is that due to our data and intelligence, this is something that we monitored daily, and as I've said before, shared with national data pools so that the patient journey could be monitored all the way through. NHS 24 from the very outset, working with SAS, understood that we needed to manage resource appropriately and get the safest outcome for patients. So over the course of COVID, we saw a gentle increase, but nonetheless an increase related to COVID time trend as people got sicker. This also aligned with the increase in the 1 hour referrals to the COVID hubs. And while we had a very high 4 hour outcome initially to the COVID hubs, as the pandemic progressed, probably within 3 to 4 weeks of the first wave, we began to see a trend of more unwell people. So, and all of that data goes into Public Health Scotland. Part of that was about measuring at-risk groups, as I said previously, people who had chronic disease or disorders that would normally get the flu vaccine, or those extremely at-risk groups that were shielding, and all of that data was being monitored.
Thank you very much. I've just got one more question, Convener, if I may.
Okay.
I don't know how you might want to answer this one, but do you think the restrictions are striking, the restrictions that we've got just now during lockdown, etc., COVID-19, do you think they're striking the right balance between minimising direct health impacts and the indirect health impacts?
Perhaps Angelina Foster.
Might be an unfair question, I don't know.
I have to say I am tempted to dodge it, given its complexities and its policy nature. If I may, I just think that's perhaps not one for us to have a view on, if that doesn't sound too defeatist on my part.
Very, very honest, I think that's the word we were looking for. Thank you, Convener. That's all my questions. Thank you very much.
Thank you very much. I wonder if I could put a variant on that question to Martin Sheen from the perspective of the board. Do you feel, does the board of NHS 24 feel that its role in dealing with direct and indirect impacts is being properly reflected in the tasks you're being asked to undertake? Martin Sheen.
Yeah, thank you, Convener. So far, NHS 24 has worked very closely with, that's not so far, we have worked very closely with Scottish Government colleagues to try and ensure that we respond to the demands of the service that we've seen. This is a rapidly changing situation, and I have to say, both the board, its governance mechanisms over the period, and the governance mechanisms have been changed slightly, enhanced, to ensure that we are responsive and fleet of foot, to ensure that we are able to respond to this changing situation. And indeed, there are some lessons to be learned as we've gone through this, Convener. We're all aware of the redesign of urgent care programme, which is coming forward, and that's something that, as an organisation, we're participating in actively, and we see clear benefits for that. So there'll be a time to review and do the lessons learned from all of this, and it's maybe not now, but we have to do that. We've done some of the lessons learned on the governance side. We've been part of a national group. All health boards have been reporting into Scottish Government colleagues on national lessons learned so far, and that will continue. So my answer to you is it's an evolving situation. We are receiving all the support and help that we've been asking for from Scottish Government colleagues, from health boards, territorial boards, and other national boards, and we're very grateful for that.
Thank you very much. I now call Donald Cameron.
Thank you, Convener. My questions are about mental health, and you've helpfully answered some of these issues already in the questions and answers that have just happened. There's a very striking graph that you provided, which shows a kind of fourfold increase in mental health calls since the onset of lockdown. And you covered what these involved. My first question is, how, as a service, has NHS 24 adapted to address that very steep increase in demand?
Angelina Foster.
Thank you. I will start this answer, but may suggest some colleagues will want to follow. I think perhaps as a point of clarification, we run both mental health services that are clinical and those that are less clinical in the very formal sense of that term. So if I take the mental health hub that we have mentioned, that has gone from 4 nights a week to 24/7 over a relatively short period of time, then that runs on a psychosocial model. In other words, It's recognising that often people are not clinically unwell. Their issues may be root cause loneliness, isolation, etc. So our response to that, to your question, has been to develop a model of skill set within the organisation that is absolutely designed around that more psychosocial model. So the name of the colleague is a psychological well-being practitioner. So that's to address that, if you see the point there. In other areas, then it's a rather more clinical focus, and so that would, where relevant, be an issue of resourcing in both instances. I'm just going to look to any of my colleagues if they want to respond. I think perhaps our Director of Service Delivery, Steph Phillips, would like to contribute.
Hi, yes, thank you. Yeah, fair to say that we have seen quite an expansion in our offering, I think, in this area particularly. As Angelina said, the hub has gone from being 4 evenings a week to now a 24/7 operation, and some of the increase in demand is obviously reflected by that additional availability. However, what we have undoubtedly seen is that there is a clear and evident need in terms of accessing that service, both in and out of hours. So we look to maintain that going forward without a shadow of a doubt. I think we've also been heavily involved with a number of partners in the evolution of our mental health services over the last couple of years, but particularly in response to COVID. So in June this year, we also became what they call a level 1 responder as part of the Distress Brief Intervention Programme nationally, as that's rolled out, and clearly there's been a commitment to sustain that in the recent programme for government as well. And we are getting around 300 referrals through that every month, which means that we are able to then link in and help people to access services locally in their community. And we've also been doing some collaborative work with Police Scotland over the last few months as well, which has now come to fruition, where callers can, accessing the 101 service, now be routed into our mental health hub. And that really is designed to make sure that we work collaboratively, because actually a police officer turning up at your front door is probably the last thing that is required in a situation such as that. So we've worked closely with Police Scotland to develop a pathway where our hub is able to take that call. Over 65% of those calls then are not being referred anywhere else within the system. So we are managing that within our mental health hub very successfully. And again, we're seeing around 300 calls a month coming in from Scotland. So quite a strong benefit, I think, across the wider system there. And beyond health, when you think about the resources required at a Police Scotland level in terms of dealing with that kind of activity. And we're keeping people out of emergency departments where it's perhaps not an appropriate place for them to be.
Thank you for that, and I'm very grateful to you, Stephanie Phillips, for addressing not just the sort of non-COVID element of this, that what was happening in the last few years, but also the fact that there's kind of inter-agency working, which I think we all accept is very important. You touched on this very briefly at the end, but is it working? I mean, are we seeing a drop in attendance at A&E departments?
Stephanie Phillips. Yep, Stephanie Phillips.
Yep, happy to come back. So the way I was describing that was we are getting roughly 2,000 calls a week coming into our mental health hub, and less than 10% of them are resulting in a 999 or an emergency department outcome. I think the challenge for us is trying to understand at this point in time whether that's new activity or whether it's a change in existing activity that was already coming into the 111 service. So part of what we will do with Police Scotland is obviously evaluate that and evaluate the benefit in terms of their attendance and indeed their transfer to ED. But from our own perspective, I think we are confident that we are reducing the requirement for other bits of our system to be dealing with these calls because our staff are able to deal with that in a more appropriate way. And I should also add as well that we're endeavouring to have a similar pathway in place with the ambulance service too. So again, really starting to join that up in terms of a more appropriate response. And I believe we will see that reduction in terms of attendance at ED from all three agencies.
Thank you very much. David.
Thank you, Convener. I've just got one final question on dental services. Sandra White, I think, has covered most of the questions I was going to raise. And I appreciate also you will just have a partial view on this. There's other operations such as dentists themselves will have a direct view. But what barriers are there to full NHS dental services being resumed with obvious safeguards such as appropriate equipment?
Angelina Foster.
With apologies, I don't feel sufficiently informed to give you a useful answer to that question. I'm not sure any of us are, but I'll check in with. No, I think we all feel that's a little bit beyond, and we don't want to waffle, Convener. So apologies, but I'm not sure we can offer a response to that.
Thank you.
Thank you very much. You've given us a good insight to the dental side of your operations already, and that's much appreciated. I now call Brian Whittle.
Thank you, Convener. Good morning to the panel. Well, we've been looking very much around the issues the pandemic has raised with putting the NHS on an emergency footing, as it were, which did result in quite a few services having to be paused for obvious reasons. I think, as Sandra White kind of alluded to, one of the concerns has been around the COVID restrictions may have led to those indirect harm and resulted in an unmet need, perhaps, and late presentation of other health conditions, if I can put it like that. So, can I start by asking the witnesses, based on their experiences, if you have, if you manage to have an opinion on which services do you think are at the forefront of remobilisation and which ones are under the most pressure to restart?
Angelina Foster.
Question was relating to NHS 24 services. Then allow me to start with a point of clarification. Although we, along with other health boards, are using the language of remobilisation because we are part of that corporate family, so we adopt that language. It is a bit of a misnomer with reference to NHS 24 and the pandemic, because unlike our territorial board colleagues who, as you will be well aware, had to stand down large swathes of planned elective procedures and so forth, that was not the case in NHS 24. It was the contrary. We were standing up additional quantities of pre-existing services and standing up completely new pathways and services. So that concept of remobilisation is a little bit misleading. What I would say as therefore that's slightly adjusted response to your question, in response to COVID, we did 4 main bundles of things, and they were these. 1, the setting up of the new national pathway that we have touched on for COVID assessment. Secondly, the standing up of the non-clinical helpline, the 0800 number that I mentioned. Thirdly, very significant expansion of all of our mental health services. And fourthly, rapid development and expansion of all our digital services. To your question, therefore, in a remobilisation context, which of those are our priorities at the moment and until global and UK circumstances change? My answer has to be all 4 of those things remain core service priorities for NHS 24.
Brian Whittle.
Thank you for that answer, Ms. Foster. Well, if I could look at it from another direction here, you'll be the front line of callers obviously coming in with the medical issues. Therefore, you perhaps can shed some light on which patients are most at risk, if you like, of the conditions that they have and what is getting worse. We're trying to put a picture together here of services that have been stood down and the condition that they're currently in. We've heard a lot about chronic pain, chest, heart and stroke, heart conditions, cancer treatments and referrals, and you mentioned yourself, of course, the issue around mental health. Do you know, could you perhaps let the committee know which conditions most concern you?
Angelina Foster.
I will start this response, but would suggest our medical director would be best placed to give a fully informed response. What we do know is that we have 10 top conditions that tend to account for the majority of our patients' needs. And they have been fairly stable. Dr. Ryan will want to say a little more and perhaps tease out for you what those 10 conditions are. But at this stage, my strong sense is that they remain a very stable package of top 10 conditions. But with the convener's agreement, yeah.
Laura Lyon.
Thank you, convener. As Angelina has said, we closely monitor all of our outcomes on a daily and indeed hourly basis. In relation to the top 10 conditions, they can vary seasonally, but in general consist of that seasonal initiative, that seasonal way of working, but also abdominal pain, headaches, fever in children and respiratory conditions. And from what I'm describing there, you can see that some of them overlap with COVID, but nonetheless, I think there is a reasonable public understanding that in the context of COVID, there are 3 very specific symptom groups. Because of the monitoring, we are able also to look at endpoints, so 999 endpoints, which may be a good indicator of severity of illness and presentation indeed of life-threatening conditions such as heart attack or stroke. And I can confirm that we have not seen any increase in the calling of 999 ambulances for those conditions, and it remains consistently at 6%. Neither have we seen a clinical analysis within NHS 24 or feedback that would reflect the fact that people were not presenting with those conditions. But nonetheless, I should go back to a previous point that when people call NHS 24, those 2 conditions are highlighted at the beginning of our initial voice directions, and those people may have chosen to self-refer at that stage back to a more emergency service. So in terms of your question, no obvious safety issues in terms of the presentation of life-threatening illnesses, and no evidence thus far of the cases that you mentioned, such as chronic pain.
Brian Whitwell.
Well, can I just finally finish this line of questioning there? I think slightly surprising, I have to say. But my question would be: is the data analysis set up to monitor that kind of, because for us, I think we are aware of, for example, the reduction in chronic pain clinics causing specific issues. We are aware of other issues like that, and so my question would be: is the data analysis set up to be able to give us that kind of in-depth analysis?
Angelina Foster.
If I may, convener, I would like Dr. Ryan to respond to that one.
Of course.
Thank you.
Thank you, convener. Thank you for that question. We do have what we call keywords in NHS 24, and the keyword is constituted from what the patient tells us is their main concern or issue when they call. Pain would be one of those keywords. Again, to go back to a previous point, if someone needs pain dealt with urgently on the call, they will be referred either to usual out-of-hours routes or during the day, if they call, they'll be redirected to their GP. So there is a person-centred approach. In terms of chronic pain, that would be part of our clinical assessment, but would be covered under the umbrella of the pain keyword.
Thank you very much. And finally, can I come to finance? And I note in the submission that you've indicated the extra costs that have come from COVID. I wonder if you're able to tell us today if the Scottish Government has committed additional financial support to NHS 24 for the current financial year, and if so, how much? Angelina Foster.
Thank you, Convener. So, yes, so we do have our year-to-date figures for COVID, which are just a little more than 3 million. And we are projecting a little under 10 million by the end of the full year. I do need to caveat that very heavily by saying that is on current service demand patterns and so forth. I have to say at the moment, even trying to predict a month ahead feels a little almost long term. So I do need to say that those numbers may well change as this pandemic progresses. But on current knowledge, it's to date about 3 million and full year 10 million. We are in, as you would expect, very constant dialogue with the government about these costs, who in turn properly challenge and make sure that we are driving down those costs as much as we can, and indeed offsetting our costs with anything that we may be able to do by an internal financial offset. So all that goes without saying. We haven't yet had a formal allocation letter, but we have indications from the government that these costs do appear to be robust and so forth, and therefore we are running our budget this year in expectation of receiving those funds that we require for COVID-specific purposes.
That, in short, will allow you to balance the books in the usual way.
Indeed so, and I would just like to take this opportunity, if I may, Convener, to point out something, which is it may well have caught the committee's eye that NHS 24 is in receipt of brokerage, and I would just like to clarify that it is, but not for the normal reasons of an underlying financial deficit. NHS 24 is in balance both in the short term and indeed in the medium term. The brokerage was an atypical reason for it, which was to allow a more value for money purchase several years ago now of a major new IT platform for the organisation. It would have cost the public purse more to have paid that up year on year, and therefore, in agreement with the government, a better deal was achieved. But for that reason, a lump sum of brokerage of 20 or so million was given to the organisation. We are on track to pay that back, and we have kept all those payments going in a very stable, as planned way. So year after next, there'll be no longer brokerage. But my main point is that there is not an underlying financial deficit, which might otherwise be the presumption when you see the word brokerage.
Thank you very much. That certainly makes the explanation clear, and look forward to the additional information on a number of areas which you've indicated you brought forward following today's session. Can I thank all of the witnesses today for your very helpful responses and for outlining the work of NHS 24 over time and in the current circumstances. Thank you very much, and we will no doubt hear from you further in due course. Thank you very much. We'll move on now to, thank you very much. We'll move on now to the second item on our agenda, which is an evidence session on the pre-budget scrutiny. This follows our general approach on budget scrutiny, which, as members will recall, follows the approach recommended by the Budget Process Review Group. We have heard from a number of organisations on budget matters over the last couple of months, and indeed, as with the evidence session we've just completed with NHS 24, our other work often informs us on budgetary matters as we go along. Last week, we heard from the Minister for Public Health, Sport and Wellbeing, Joe Fitzpatrick, answered a range of questions from committee members. This week we're hearing further from the Cabinet Secretary for Health and Sport, and I welcome Jean Freeman to the committee, and also Richard McCallum, Interim Director of Health, Finance and Governance at the Scottish Government. As previously, we will take questions in a pre-arranged order, and we will seek simply to fill in the gaps from the sessions we've already had, and look forward to the responses. And can I start by inviting the Cabinet Secretary to make an opening statement, and look forward to that. Cabinet Secretary.
Thank you very much, Convener. And can I start by thanking you for your flexibility in accommodating my attendance at the committee. As members are aware, the events and announcements of last week required the reprioritisation of time, and I'm very grateful to Mr Fitzpatrick for attending and answering your questions in my place. I also want to say, before I go any further, for the record, again, my sincerest thanks to all our NHS and social care staff for the considerable amount of work they have done in meeting the challenge of this pandemic and continue to do. In recent years, we have tried to ensure that we put our health services on the strongest possible footing, but we do need to go further in embedding a world-class public health system and sharpening our focus on population health. The pandemic has demonstrated the positive changes that we can make to how and where we deliver healthcare, and we need to lock that in. By accelerating the transition to a new model of community NHS care and supporting the digitisation of services such as NHS Near Me, we can ensure that people receive the right care in the right place and at the right time. In terms of funding for our health and social care services, while the pandemic has had a massive human cost, it has also come with significant financial implications for our frontline services, and it is essential that funding is in place to meet additional COVID costs. We have acted quickly as a government and put in place the necessary infrastructure to support rapid decision-making and approval of spend, balanced against due governance around public spending. We agreed an initial funding of up to £100 million to ensure the sustainability of social care services, and I have been clear with the committee in the past that we would provide the necessary level of funding across health and social care following the conclusion of our detailed Q1 review of expenditure. Now that that review is concluded, I have confirmed to the Parliament this morning and to you, Convener, that we are making available £1.1 billion for NHS boards and integration authorities. This provides boards and integration authorities with funding for additional COVID expenditure already incurred and provides the necessary funding for the coming months, including support for remobilisation, social care, for our NHS Test and Protect programme, PPE and hospital staffing levels. My officials have worked closely with NHS boards, integration authorities and COSLA in reviewing financial implications and developing the most appropriate funding approach for our health and social care services. In making this funding available, I want to be clear on two important points. Firstly, I recognise that some areas have been impacted by COVID costs in a significantly disproportionate manner. Our funding therefore takes account of these disproportionate impacts while also recognising the need to distribute a resource equitably and transparently. I also recognise that some boards and integration authorities will require further support beyond the level confirmed today, and I will consider all such requests carefully and expect that these will be properly evidenced. Secondly, in making today's funding announcement, I am also confirming that we will undertake a further substantive funding allocation in January. This will provide the opportunity to better understand the implications of COVID across the sector for the remainder of this financial year and will ensure that our frontline services continue to have the funding they require. Finally, Convener, and as I am sure you will agree, In terms of pre-budget scrutiny for 21-22, it is essential that our health and social care services have the funding certainty that they need both for this year and for future years. As my colleague Ms Forbes made clear last week, this is made additionally difficult and is unacceptable that Scotland and other devolved administrations are facing a delayed UK budget once again. The Scottish budget envelope is tied into the UK block grant set by the UK budget and the UK tax policy, and a delayed UK budget creates huge uncertainties for the Scottish budget, for our NHS and for social care. It is impossible to plan with certainty without that information. I can assure you, Convener, that I will continue to do everything that I can to support our frontline services, to ensure that the necessary funding is provided throughout this pandemic, and to support the delivery of a world-class public health system. In announcing the £1.1 billion funding today and committing to a further substantial funding allocation in January, I do also hope that the UK Government quickly changes its position so that in January we're able to provide our NHS and integration authorities with the certainty they need for next year and beyond. All of that said, Convener, I'm very happy now to take any questions that you or members may have, and if I may call on my colleague, Mr McCallum, for any detail that I may not have immediately to have.
Thank you very much, Cabinet Secretary, and that's much appreciated. Can I start then where you finished, I guess, around the budget for this year and next? You've talked about the delay in the UK budget. In terms of the commitments you've given for passing on consequentials, clearly I anticipate those commitments remain in place. Beyond the consequentials of which you are currently aware and which you are able to budget for, have you taken any policy decisions in relation to any additional funding which may be required in order to maintain the level of services that you have assessed as essential? And if so, what estimate have you made of any potential gap there may be between borne consequentials and current and future need?
So, as I think Mr Fitzpatrick explained to the committee last week, we remain in a very fluid situation in terms of the anticipated demand. So, for example, if you take PPE, we are modelling the demand for PPE in the coming months through to the end of this financial year on the basis of the demand that we saw in March, April and May. So that implies, and it is correct to imply, that we will continue to supply PPE through all those channels that we develop. So to our acute setting, to primary and social care, to unpaid carers, using the distribution routes and channels, to pharmacy and so on. So we can model the demand of what we anticipate the situation might be in terms of COVID and how the pandemic may play out, both in a worst case scenario and in a best case scenario, and calculate spend there based on what we know we have spent and that 1.1 billion that we have already allocated. What is more difficult to do is to understand and to continue to model and remodel how the behaviour of the pandemic may impact on the level of remobilisation of services that we require and that we would wish to see. I think, as I said in a statement to Parliament not too long ago, we need to, in thinking about how we remobilise the NHS and therefore what might the cost of that be, we need to understand the other pressures on the NHS, not only in responding to COVID in terms of hospital admissions or ICU or impact on primary care, but also the demand on the NHS from Test and Protect and from the very important flu vaccination programme this year, which is intended to reach a larger number of individuals than in previous years, having added to the cohorts who are eligible. So that is a constant planning exercise where we flex and discuss with our boards and the integration authorities, some of the integration authority chief executives I'm speaking to later this morning with my colleague Councillor Curry from COSLA. So it's a constant exercise, but it is in large ways determined how far we can move forward, how far we need to have resilience in the system based on how the virus is playing out in terms of outbreaks, our capacity to contain those, and our overall intent in suppressing the virus to prevent community transmission but contain those outbreaks. That may mean from time to time that we need to further increase the resource that we put into test and protect beyond what we had originally planned.
Thank you very much. One other question which did come up last week, but I'm interested to know if there's any more certainty around it, was the question of resources moving from those areas where there was lower activity in health provision in the course of 2020 to other areas where there is higher need currently and going forward. I wonder if it's possible to quantify any shift in spend from areas of lower activity to areas of higher.
So we have been able to do a degree of work on that, and if I may, convener, I'd ask Mr. McCallum to give you what detail we can at this time, bearing in mind that that is not by any stage at this point final.
Mr. McCallum.
Thanks, convener. I think there's two elements to this. One is in the immediate, there might be some short-term offsetting savings for health boards. As a result of COVID, they've maybe not been able to take forward some services as planned, and therefore some of the variable costs associated with that, they won't have incurred. And so there will be some offsetting savings in the short term. And so as part of the review that the Cabinet Secretary mentioned that we've undertaken with health boards, one of the key things that we're looking at is where those offsetting savings are. And I think you would expect that as part of the robust financial governance that we're undertaking. The second strand to it is the longer term approach and where there might be shifts moving forward. We've already started to see that shift in the balance of spend. And I think in some ways it's too early to say, and I know that's probably unhelpful to say that at this stage, but I think as we go through the next few months and we start to see some more of the investment that we've seen in the community, I think we'll be in a better place to assess how much of that shift has happened, both in the short term and how much that might happen in the medium to long term as well.
Thank you very much.
I didn't quite catch there what you said because I lost a bit of signal. I'm assuming you're asking for me now.
I am indeed.
Okay, thank you very much. Good morning, Cabinet Secretary. It's a couple of questions about Barnett consequentials, and one of my questions basically says that the Scottish Government has indicated that £500 million is to be allocated to health boards in respect of the first quarter of 2020-2021. Is this in line with the amount set out in the mobilisation and remobilisation plans submitted by the boards, or will some boards receive less than their estimated spend?
Cabinet Secretary.
So the 1.1 billion that I just mentioned is distributed to boards largely on the basis of the NRAC formula, but with what I think Mr. Fitzpatrick described last week as a hybrid approach, because we do recognise that some boards will have rightly and appropriately incurred a higher level of costs than the formula would necessarily refund them for, not only in terms of the costs incurred, but the future planned costs. So in working through with boards individually, and that includes also working through with health and social care partnerships, we're aiming to make sure that where boards have incurred additional costs beyond that they would receive through the formula, that we, provided it is properly evidenced and we have that iterative process of challenge and scrutiny that I described, Mr. McCallum has described, that we reach an agreed position with the board, then that additional funding will be provided to them.
Emma Harper.
Okay. Cabinet Secretary, are the Barnett consequentials sufficient to cover additional expenditure expected? Or if not, how will any gap be funded? Cabinet Secretary.
So the Barnett consequentials at this point are £2.5 billion. As I've said, we have allocated this month £1.1 billion as a result of the Q1 review and looking ahead at what we anticipate boards' costs to be. And we have said, as I said in my opening statement, that we will look again at this in January. Whether or not the Barnett consequentials will be sufficient to meet all the additional expenditure is almost an impossible question to answer at this point. Additional expenditure in health. Other parts of government will have their own views about the impact on their own portfolios. And that is because at this point I do not know if further consequentials may come, and that in part depends on the continued discussions that we have with the UK government and with Treasury on, for example, areas of social care. So we are not yet clear whether areas of additional consequentials may come at this point. But at this point, we have been able to use that funding, as I've described, to hold back some funding that we believe will be needed in January for boards, to allocate some of that Barnett consequential amount to planning for a second wave and being sure that we are prepared for that, and in terms of PPE and other areas where we're not finally clear on the exact amounts. But at this stage, every penny of those Barnett consequentials will be used for health and social care. Whether or not they will add up to all that we need to spend in that area is not entirely clear to me at this point, remembering that we gave a very clear commitment to COSLA that we would resource what was needed in social care in order to meet the challenge of COVID. And we have introduced, for example, the Social Care Workers Fund. We've taken steps in terms of death and service benefits for health and social care workers, and covered indemnity requirements across those areas as well. So we have taken a number of additional measures that will incur a cost, but we did that because we believed those were the right things to do.
Emma.
Okay. Thank you, Cabinet Secretary. You described that this whole situation is really fluid, and you know, each day is obviously a real challenge to protect and to project and plan any financial, I guess, process that you want to move forward. And obviously that is an additional issue, the fact that we don't have a Westminster government that has a budget or is proposing a budget that then you can then work with. I'm sure that is really, really challenging. And also one of the things that we took evidence on was about appropriate additional costs. Are you able to give some examples of what appropriate additional costs could be considered? You've described already additional social care funding.
So appropriate additional costs can range from PPE to additional staffing, for example, that may be required to allow a service to be delivered. Additional staffing that is needed, for example, to accommodate the fact that productivity is reduced because of the additional level of PPE that staff have to wear, and therefore the normal volume of patients that they might see is reduced. So we want to, in those instances, increase the number of clinics to still, if you like, see the same volume of patients, because it takes us longer to see them because of PPE requirements. Appropriate costs may also include some level of capital cost in order to reconfigure aspects of the estate in order to ensure that we maintain that COVID pathway and a COVID-free pathway. The establishment of the hubs and the assessment centres, some additional funding for NHS 24, for example, to take on, as they have done so well, the significant additional asks that we have made of them in order to continue to provide a level of service when that is not possible to do face-to-face, and that is particularly in the way that we've scaled up NHS Inform, but also the way that we have used digital to try and provide a significant range of mental health support to different aspects of the community. So appropriate additional costs cover a range of different items that health or social care may require in order to continue to deliver the best service that they can in the face of an ongoing pandemic.
Emma.
Thank you. What methodology or formula is being used to allocate the initial tranche of funding for Q1 of 2021? You described earlier, and indeed Joe Fitzpatrick described last week, an NRAC hybrid approach. Is that the methodology that will be used for 2021 initially, and then for future allocations as we go forward?
Thank you very much. The hybrid model is really in place in recognition of the impact of the pandemic has differed between different boards. So it is a reflection of that recognition that some boards have been disproportionately more impacted in responding to the pandemic as opposed to others. So the NRAC formula is there, it's agreed, it's there to provide a degree of equity of allocation, so it is the foundation. But as I said, where boards can evidence that they have additional costs beyond what they will receive through the NRAC formula, then provided there is evidence for that and we go through the proper process led by Mr McCallum on scrutiny and challenge, when we reach a settled position, then those boards will receive that additional funding over and above their NRAC formula.
And just for clarity, Cabinet Secretary, I think the impression we had formed from last week was that there would be a consistent methodology to addressing this issue. But I think from the way you've described it in deciding what is required beyond NRAC, I think you're describing a case-by-case approach. Is that correct?
Yeah, yes, it is, because it recognises, as I say, that different boards have been impacted in different ways. Now, that inevitably places a greater burden of work on Mr McCallum and his colleagues, but it seemed to us to be the fairest way to address any individual board's case that the NRAC formula in and of itself was insufficient to properly reimburse them or allow them to future plan for the additional costs that COVID was bringing in their direction. So that is the approach we've taken here, and I expect it to be the approach we will take again in January.
Thank you very much. Can I now call Donald Cameron?
Thank you, Convener. Can I begin by saying I'm grateful for the clarity about new COVID spending announced today. That's obviously welcome, especially as the Minister was unable to answer my questions on this last week. I have to say that given that this committee has been undergoing pre-budget scrutiny for months now and has only just been presented with these new figures during its meeting this morning, I do find that the Cabinet Secretary's criticisms in terms of not obtaining information, financial information from the UK government, somewhat ironic. Can I turn to address the position under social care? Can I ask the Cabinet Secretary, how have decisions been made on how much to allocate to social care, and were they based on an analysis of need, or were they based on Barnett's received in relation to social care?
Cabinet Secretary.
So, two things to say, and in terms of some of the detail of how we have worked with the Convention of Scottish Local Authorities and the IJB's Chief Finance Officers. I'm sure Mr McCallum will have some detail to add to that. I have to say for the record, Convener, undertaking proper due scrutiny, challenge and coverage of individual board returns and then reaching the position that we have reached, which has been conveyed today, is not in any respect to any reasonable person comparable with the UK government refusing to allocate and determine a UK budget in the appropriate time, and which shows utter disrespect for the devolved administrations. The two are not comparable. I'm sure Mr Cameron and I will have that argument elsewhere on another day. Mr Fitzpatrick could not have given you that figure last week, and if it had been me last week, I couldn't have given you either. No reflection at all on Mr Fitzpatrick, or indeed myself, but a reflection on the thorough way in which we have approached with our boards the proper look at what was the expenditure incurred in Q1 and how would that forward plan to take us up to the early part of the next calendar year. In terms of social care, we made the commitment in 20th of March that I've referenced already, that we would support reasonable funding requirements and any additional expenditure being fully aligned to local mobilisation plans. In other words, any additional expenditure above the increase in the Scottish budget that social care and IJBs were incurring in responding to COVID, that we would support that. We have worked through with the IJB chief officers and with our colleagues in COSLA. We must remember this is a joint exercise between Scottish Government and COSLA in terms of the funding and delivery of social care. We've worked through that with all of them. We've already committed, from memory, is £100 million additional funding, and we continue to work that through with IJBs because in some instances we do not yet have from them the evidence of the additional spend. But the detail of how we have gone about that, if I may, Convener, I'd ask Mr McCallum to take us through that.
Richard McCallum. Can we get Richard McCallum, please? We may have to come back to Mr McCallum in due course. Can I call again Donald Cameron?
So, sorry, I've come in now. If I can just add 2 points to what the Cabinet Secretary said. Firstly, in terms of the approach that we've taken with social care funding incurred so far, the allocation that's been committed today includes all of the funding that IJBs have estimated in relation to social care for the first quarter. So we've worked closely with chief finance officers from integration authorities who understand the costs that they've incurred in the first quarter, and the allocation is based on that actual forecast, actual spend. In terms of the second thing is, in terms of forecast for the remainder of the year, what we've agreed with integration authorities is at this stage we'll provide 50% of their assumed future costs in relation to social care, with a view to reviewing that in November once they've had more detail received from their providers, whether that's in the voluntary sector or the private sector. It's taken integration authorities some time to work through all of that detail with their providers, and so that's why we think doing that further review in November will allow us just to be absolutely clear on the full costs of the year. But that's the approach that we've taken so far, and that's about 150 million that's been allocated for social care as part of today's commitment. Thank you.
Thank you very much. Donald Cameron.
Thank you, Convener. In terms of scrutiny arrangements, internal scrutiny, what arrangements do you have in place in respect of additional social care spending? Is it the same for health and social care, or is there a different approach?
Cabinet Secretary.
But I'm not entirely clear what Mr Cameron's question references. You mean internal government scrutiny, or?
Yes,
more than
in terms of... Sorry, thank you, Convener. So the autumn budget revision states that a total of £220 million was transferred from the health budget to local government in respect of what might be called social care. And I'm just interested in how that is scrutinised internally in terms of governance, in terms of spending, what's been spent, what hasn't been spent, etc.
Cabinet Secretary.
So that is led by Mr McCallum and then signed off by me. Mr McCallum, I'm sure, will be happy to take you through the detail of how he goes about that.
Richard McCallum.
Okay, a couple of things then. I think firstly on the 220 million that Mr Cameron refers to, that was agreed as part of the budget settlement for 2020-21, this current financial year. And that 220 million is funding that's passed to integration authorities to support the delivery of social care. So that's slightly different to the money we're talking about today in relation to COVID response in particular. In terms of how we go about scrutiny of delivery of outcomes against that funding, I suppose there's two main approaches that we would take. Firstly, one of the benefits of integration is that we now have a pool of chief officers and chief finance officers that, as government, we have close relations with, and so we have an opportunity through one-to-one sessions, but also meeting with them as a group to scrutinise the progress that's been made on spend. And the second thing I suppose I would just highlight is, as we discussed, or as I said earlier, that 220 million was part of the budget settlement, and there was a range of outcomes that were anticipated would be delivered for that. But it's really the scrutiny against those outcomes is how we take forward that approach with funding for social care, as we do for other parts of the system. I think the key thing I would add, though, is with it being alongside integration authorities, as the Cabinet Secretary has already alluded to, we work closely with COSLA on these things as well, and these matters, recognising that this is a partnership between health and local government.
Thank you, Convener. My final question is about future sums that may be directed towards social care, and my question is, how will these be agreed? And will that be in line with the amounts identified in the mobilisation and remobilisation plan?
Cabinet Secretary.
So there will be two areas of future funding for social care. The first will be a continuation of what is in the current Scottish budget, and in terms of additional funding for COVID expenditure, then that will follow the same process that we have adopted up till now and will be against those local mobilisation plans. The final point I would want to make on that is just to repeat what Mr McCallum touched on there, and that is it is really important that we understand that the relationship between Scottish Government and the NHS and the relationship between Scottish Government and the integration authorities is a different relationship. In terms of the integration authorities, it is a partnership approach with COSLA, and therefore, for example, every single NHS board produces an annual operating plan that sets a series of outcomes, financial requirements, areas of spend, which we agree with them, and they are then, in terms of at the end of each of those years, their performance is assessed against those very detailed plans. The approach with integration authorities is different because, as I say, it is a partnership approach with COSLA. So that degree of detail is not there, but outcomes are the focus of the work that we undertake with them.
Thank you very much. Georgia.
Thank you, Convener, and good morning, Cabinet Secretary. You know, Donald Cameron is quite correct. Cabinet Secretary, we have for the past couple of months been diligently going through the budget process here, but just for my own clarity, you know, bar Mr Cameron throwing the toys at the pram a couple of minutes ago, just for my own clarity, you know, we spent this time going through this process, You've spent the time, Cabinet Secretary, dealing with a worldwide pandemic on your doorstep. And is it not the case that any disrespect that has been shown to us here has been that of the Westminster Government by not actually having a budget and by postponing that for the future, considering all the pressures we are under at this moment in time? Is it not the case, Cabinet Secretary, that the Westminster Government have been totally disrespectful to the devolved governments?
Briefly, Secretary.
So I certainly would hope that there has been no disrespect shown by me or any of my ministers or officials to this committee. That would be the last thing that we would wish to do. I think it has been and is disrespectful of the UK government, not only to not have a budget at the normal time, but not to have the courtesy of advising our Finance Secretary of that change in their position, such that she found out on the basis, I think, of social media or perhaps even mainstream media coverage. That does not help us work cooperatively as the governments of the nations of the United Kingdom, far less as equal partners in that endeavour. And it does make it exceptionally difficult for us to know how we will plan our spend and what degree of stability and security we can give to our NHS and to adult social care, from my perspective in my portfolio, for the years to come. And, you know, a great many people are anxious about what happens in 21-22 and the years beyond. And it is very frustrating, to say the least, not to be able to engage with them in meaningful conversations at this point, because we do not know in what way the envelope of the UK budget, which we are currently irretrievably tied into, at this point at least, what way that will impact on our planning and our resources.
George Allen.
Thank you, Convener. I'd like to move on, Cabinet Secretary, to some of the questioning that I asked last week, which was adequately answered by Joe Fitzpatrick about community hubs. We're all aware that the summer budget revision identified spending of £35 million on community hubs, and were established to provide frontline community response for those affected by COVID-19. Now, hub services were aimed to facilitate face-to-face scheduled appointments for individuals needing further clinical assessment. Now, there's been different ways of working that's been found by using these community hubs. And one of the questions I'm interested in is how much of that new way of working will be retained post-pandemic or as we move forward in the future?
Cabinet Secretary.
It is, if I may say so, a very good question, and it is our intention to retain the approach that the community hubs and assessment centres developed very, very quickly and stood up very, very quickly. But it is our intention to retain that. Right at the moment, we are holding them also ready to stand up should we see a significant increase in the number of cases beyond where we are just now in managing major outbreaks, but they are contained outbreaks. So we need to, as we do with the NHS, have it there ready to respond to any increase in COVID cases as it did in the period March through until the early summer. But at this point, we're also looking at how we can make use of the infrastructure that is currently the community hubs and assessment centres to help us with a redesign of unscheduled care to ensure that people do receive the right care in the right place. Not everyone who currently attends A&E, that is not the right place for many of those individuals. But if we want them to go to the place that is right for their needs and for their care and is more local to them, then we have to be able to provide that. We can do that through community pharmacy and having stood up Pharmacy First. That is a major step forward. but we're also actively looking with our clinical leads, with those actively involved in both acute and emergency department care, but also in primary and community care, how we can use the infrastructure of community hubs and assessment centres to help us with the redesign of urgent care.
Thank you, Convener. Yeah, part of that redesign of primary care, or how we deal with the patients as they go through the process, would be, the impact community hubs have had on GPs' workloads. Now, do you believe there has been an impact? Has it helped GPs' workloads? And is it maybe a way for us in the future to find a way to find these different ways of working, using these hubs as a way of working, as opposed to everybody automatically thinking they have to go to their GP? Very similar to the A&E answer you gave me earlier on. A lot of the time, A&E is not the first place people should go. Likewise, a GP's office might not necessarily be the first place to go.
Cabinet Secretary.
So I think it's a very good point. I mean, the hubs and assessment centres were stood up in order to create a COVID-safe, so a non-COVID route via your GP for any healthcare needs that people had. It was an attempt by us, I think successfully, to ensure that people who had healthcare needs could continue to be seen and treated by their GP, often digitally, of course, but nonetheless, the GP practice was COVID-free, if you like, and those individuals who had symptoms of COVID could be assessed in through the hubs, and if necessary, seen and treated in the assessment centres. So that then offers us a way of, given that we have the infrastructure, that it would be crazy to disband that and just go back to the old ways. So it does offer us a way, in consultation with GPs, with community pharmacy, but also with our clinicians in secondary and tertiary care, to identify what would be an appropriate use then of that infrastructure, so that we can see people who, as you say, for whom the GP practice may not be the right port of call. Equally, A&E may not be the right port of call. How can we assist in that? And alongside all of that goes the work that Ms. Hockey is leading, which is a redesign, a transitioning into a new shape of delivering some particularly crisis mental health services, where most certainly A&E is not the right place for individuals in those circumstances, but nonetheless they are in crisis, and so an emergency response is needed. Some of that we saw through the pandemic. We have a good example of that, for example, in Greater Glasgow and Clyde. So it's about developing that alongside other health boards, and as an example of lessons that we have learned in what was a very rapid response to the pandemic, but produced some very important new ways of working and new practice in the delivery of healthcare.
And one final question, Cabinet Secretary. Obviously, as we look to mid to long term, how we may be looking at working differently, how do you think these community hubs, what kind of implications and impact could that have on future primary care funding? Obviously, if we're looking at doing things differently, we might be putting money towards that as opposed to traditional methods. So what kind of impact would there be mid to long term on primary care funding?
Cabinet Secretary.
So we had made good progress to deliver more than half of spend into our community, our primary and community health services in this financial year. We'd got to 49.7% of funding in 2018-19. The figures for this year will be, for 19-20, have been delayed, but we expect them in early next year. So we were making good progress in that area. I am absolutely determined that we will continue to make good progress in that. In the board remobilisation plans, in the Remobilise, Recover and Redesign NHS work, that we commission from our boards, recognising that that will not move at the pace that we would all ideally wish, because we do still have a pandemic on our hands. But in that commissioning to them, I was very clear that I wanted to see a significant focus on healthcare delivered through primary and community healthcare settings, and a very much closer link using the experience of the pandemic and the partnership working between health and social care. So we continued, for example, the wraparound primary care service to our care homes in that much more systematic way that we have seen now through the pandemic than perhaps we had seen before. So I think there are significant opportunities that we need to continue to drive forward in terms of how we refocus healthcare into primary and community care, much more local to people, making maximum use of pharmacies and other services, so that acute care becomes exactly that, the place that you need to go when that clinical treatment cannot be offered safely to you in any other setting.
David Charles.
Thank you, Convener. Good morning, Cabinet Secretary and Mr McCallum. How is NHS Louisa Jordan currently being used, and is this providing value for money, Cabinet Secretary?
Cabinet Secretary.
So NHS Louisa Jordan remains. As you know, we have extended the licence on it to April next year in order to ensure that we continue to have that additional resource should we need it in the face of either increased cases or, as it is currently doing, to assist us in working through some of the outstanding healthcare needs. So it has been used for orthopaedic and plastics patients. It is also being used for a degree of diagnostic work, and it is being used for staff training, teaching and examinations. Really important that our staff can continue to follow their training and their learning, which has been disrupted because of the pandemic and the response to the pandemic. So to be able to have a COVID-free space, a known COVID-free space, where those clinics and facilities can be made available is really important. So we'll continue to use NHS Louisa Jordan for that. We're looking at what more can safely be done there for patients in terms of day case surgery and other healthcare procedures, and additionally, of course, as I said, diagnostics. So having invested in the build of the Louisa Jordan, completed very quickly and within budget, then it makes considerable sense for us to give ourselves the security of knowing it will be with us at least until April next year, and we can maximise its use for the NHS, whether that is for COVID or not. It is still for the NHS and for patients.
David Charles.
Cabinet Secretary, with the potential for a second wave of COVID-19 infections, is the NHS Louisa Jordan a good example of pandemic planning by the Scottish Government, and is it ready to treat COVID patients if needed?
Cabinet Secretary.
I think it is a good example of the right kind of planning that you need to do for two reasons. First of all, it was established to deal with COVID patients should our standard NHS estate require that additional resource, and it remains ready to do that if it is required to do it. But until it is required to do it, it is also there for us to use to deal with any backlog in terms of patients who could not be seen in those months when we were dealing with the pandemic at its worst at that time. So at this point, it feels to me that it is a very good use of additional resource, and it is making a difference to patients in Scotland.
Thank you very much. Now call Brian Whittle.
Thank you, Convener. Good morning, Cabinet Secretary. I'm looking really around the preparations for the potential of a second wave, which unfortunately seems to be on its way. I think it'd be fair to say that the first time round, I think governments, may I say, weren't particularly well prepared for what the eventuality was. So can I ask what funding has been made available to support preparations for a potential second wave of the virus this winter?
So there is a, excuse me, I think I gave that, excuse me, Mr. Whittle, I'm just nipping back to check. At the moment, we have set aside 0.3 billion as second wave preparedness. There is a lot of planning that is going on. I mentioned the board mobilisation plans earlier. Those mobilisation plans are caveated in that boards have also been asked to retain a capacity in bed numbers in ICU should there be a significant increase in hospital admissions from COVID. They maintain their red and green pathways, of course, and they are also contributing to controlling the spread of the virus through the NHS Test and Protect programme, and will significantly lead. It will be our boards that will lead our flu vaccination programme this year for 2.25 million people. So that is all part of their mobilisation plans. Our social care is also engaged in looking at what more it needs to do in terms of winter preparedness, and subject to the Bureau's agreement, I hope to be able to set some of this out in detail to the Chamber as a whole before we get to the October recess. So winter planning winter planning is a normal part of what happens every year, but this year it is winter planning in the context of having a pandemic and a virus still there and still as capable of causing significant harm as it was in the spring. And so boards have, as I say, undertaken that work, knowing that they need to hold a degree of capacity ready, not empty right now, but ready to be stood up if it's needed. At the same time, our NSS, our National Procurement Service, responsible for PPE, has been ordering and planning its PPE supplies based on, as I said earlier, modelling the demand, using the demand that was there in the peak months, and retaining all the distribution outlets and routes that we had before. Excuse me. One other point I should make is that boards also have to be planning for Brexit and the possibility of no deal. So that includes work with our counterparts across the UK, looking to ensure that we have medicine supplies and stocks, and that we can prepare as best as we can in those circumstances. Excuse me.
Thank you, Convener, thank you, Cabinet Secretary, for that answer. We heard from Ayrshire and Arn, NHS Ayrshire and Arn, that if there was a significant second wave, we'd obviously have to go into a similar station of activity, if you like, to take that safety precautions that are required. And that would look at the issue around cessation of elective treatment. Can I ask Cabinet Secretary what the cost implications of that, and what would be a trigger to return to those kind of lockdown measures?
Cabinet Secretary.
So the trigger question is one that is asked a lot, and I think it was raised at the last session with Mr. Fitzpatrick. I genuinely do wish there was a magic number or a magic indicator that we could say when it gets to there, then we do X or Y. It unfortunately doesn't work like that. There are a number of indicators that we look at, excuse me, every single day and weekly, and those indicators you'll be very familiar with. They're in the number of cases, but not just a number, where they are, what has produced them, what is the level of modelled infectiousness in the community that comes from some of our surveillance work that Roger Halliday and his colleagues publish on a weekly basis. What's the R number looking like? So there are a number of factors to be taken into account before you would conclude that you had a level of community transmission that would constitute a second wave. At this point, although our case numbers are high, they are in outbreaks. They're not in community transmission. So the complete focus right now is to contain those as much as we can, just as we did in Dumfries and Galloway, in the Two Sisters outbreak, in Aberdeen, and to try and take additional measures that ensure that as we try to contain the outbreaks, we also protect against community transmission. So it's a twofold approach, some of which I'm sure I'll be discussing with the COVID committee tomorrow. So there isn't actually a number or a trigger that I can give you. I hope the explanation, though, is reasonably clear. I think we're also, well, I know that we're also considering the different scenarios that if hospital admission and ICU admission rose to what kinds of levels, what would that mean for the cessation of other work? I'm trying very hard not to have a position where we simply stop so much as we stopped last time. That's partly informed by the fact that we have test and protect to the scale that we do have it. We have a growing understanding of the virus and how it operates and who it impacts on. And we are able to look across Europe and see, whilst we have an outbreak just now, very largely in the younger age group, we can anticipate a lag nonetheless, but we will see increased hospital and ICU admissions. So taking all of those factors into account, how might that work for us in terms of having to halt those healthcare services and procedures that we have begun to remobilise? Bearing in mind too that, for example, in elective work, boards plan 6 weeks ahead. So patients are getting appointment times 6 weeks ahead or less, but that's their planning cycle. So you need to take decisions fairly early on if you want to stop something that has already been planned 6 weeks on. So I'm aware, Mr. Whittle, that isn't a definitive answer, but it is the best explanation I can give of how we are trying to work our way through this whilst understanding what's happening with the virus in the community and in those outbreak areas and what that then necessarily means for the health service, but trying very hard not to get back to a place where we cease activity across a whole range of areas.
Brian.
Thank you, Cabinet Secretary. No, I think I get the I understand. Correct me if I'm wrong, Cabinet Secretary, but I think what you're saying to me is that any sort of return to lockdown measures is going to go predominantly on the general community transmission, not in outbreaks. And I think that's very helpful. I think the question I want to ask is around the modelling of the financial requirements. If that was the case, cessation of elective treatment, and the cost implications also of keeping NHS Scotland on an emergency footing, if I could ask that.
Cabinet Secretary.
So I don't know if Mr. McCallum can help here. There is, as he indicated earlier, there is a degree of saving if you stop doing elective work, for example, and you redeploy staff over into other areas. We know what the cost of dealing with the pandemic has been so far. Our Q1 conclusion tells us that. So those are the numbers that we have to work from in planning what might be the cost of any second wave. Of course, it is not clear, and it cannot be clear at this point, if there is a second wave, when might that appear? Because our overall objective just now is to ensure that we don't see such a thing by the effective deployment of test and protect and the increased compliance by the public in Scotland, who have complied so very well with the restrictions that we're asking them to comply with in order to prevent transmission. So we need to plan as best we can for the detail of how we would respond to a second wave, and our estimate of the cost of that has to be based on what we know has been the cost of dealing with the pandemic so far. Don't know if Mr. McCallum wants to say any more.
Yeah, maybe just two things. So to pick up the Cabinet Secretary's point, there will be some short-term savings as a result of not taking forward some services. I expect that will be fairly negligible, as most costs for health boards are staff and bed costs, which are fixed by nature. And I suppose what we need to work through, and what we will be working through, is the impact of the delays in elective treatment as we move forward into future years, and what will be the financial implications potentially in future years. And obviously finance isn't the only factor in that. There will be questions in terms of capacity and other things. So I think, looking ahead beyond the current pressures, we need to see where we will be coming out of winter and how that will be managed. But I think one point I would make is just the approach to the elective centres and bringing those on stream to help potentially deal with some of that backlog will be really key. And obviously that's part of one of our key focus in terms of both our capital and revenue investment for 21, 22 and beyond. And I think that will be a key driver in supporting our elective strategy beyond this winter.
Thank you very much. And now call Sam.
Pardon, sorry, Convener, did you say me or?
I did.
Right, thank you. I couldn't make it out there. Thank you very much, and good morning, Cabinet Secretary and Mr. McCallum. Also, I think you've possibly answered a number of the questions I was going to ask in regard to the innovative way that we're working now. George Adams, I think you answered his questions roughly the way that I was going to ask, delivering services such as near me and digital services as well. So I may just go straight on to the financial budgetary point in that particular part. If these services are retained, the new innovative services, and I think you said yourself, Cabinet Secretary, in regard to hospital-based care, you prefer it in the community if at all possible, less reliance. Can you put a figure? I mean, I think we don't all have crystal balls, obviously, and we don't know what the budget is going to be yet either. But would you say we would have savings in the health service budget, in the future even, if we're looking to these new models?
Cabinet Secretary.
No, I don't believe necessarily that we would have financial savings in the health service budget. What we would see is a continued focus on moving spend into the community and primary care. Of course, acute care develops all the time, and we know that precision medicine and genomic science, all of that produces significant advances, which you primarily see in acute care. I recall the days when having a hip operation meant many weeks, some weeks certainly in hospital, and now in NHS Fife, some hip operations, depending on the nature of the operation, hip replacement operations of the replacement to be undertaken and the patient's own health, can be done in a day, as a day case. So the advances in science will see improvements in patient care, improvements in pain management and pain relief. And in that sense, what you see is improvements. You see improvement in people being able to receive the right care closer to home. But at the same time, you see increase in medical advances, particularly coming through in acute care, which aren't cheaper than what you had before, but are better for patients because their hospital stay is less and so on. So you see more patients because you don't need one patient to take up a bed for a week if they're only there for 2 to 3 days, which I think is probably the standard now at Golden Jubilee. Then therefore you can see more patients in that time. So I'm not convinced that these improvements will necessarily produce significant financial savings, but what they will do is produce a continued improvement in patient care.
Thank you, Cabinet Secretary. If I just follow that on, I presume that it's an improvement in well-being, and that's what we all want. I just wondered, when we're looking at the different innovative ways, have we looked at the patient views on this particular matter? Are we going to look at model delivery, ask patients' advice or how they feel about it, and evaluate the outcomes, perhaps?
Cabinet Secretary.
Excuse me. So I don't have it to hand, but they did publish this. The people in charge of the Near Me technology and that way of delivering service did undertake a survey with those clinicians who had used it, primarily in primary care, but also now in acute, and with patients who had used it. And they have produced a result of that work which shows overwhelmingly that patients preferred that way of consulting with their clinician or their GP or whoever it might be. It doesn't remove the need for face-to-face consultation, either on the part of the clinician or on the part of the patient, if that is what they prefer. But as a significant addition to the delivery of care, then it is proved itself over the course of the pandemic, in fact. There will be other evaluation work and surveys undertaken in other ways of improving the delivery of care. And as you know, the Alliance, the Health and Social Care Alliance, is a member of the Mobilisation Recovery Group that I chair, and they have been tasked with doing a piece of work for that to get the patient's view of how they would like to see their NHS look and how they would like to see their healthcare services delivered.
Thank you for that. I'll certainly get the committee to get a copy of that. Just one last question. It's about working from home, office workers, obviously call centre, whatever it may be. We've had comments from health boards saying that there is more and more people working from home working staff involved and not involved in frontline services. Do you think there's a role for more centralisation of office-based functions? And to go back onto the budgetary part of it, would that be cost saving for the health service?
Cabinet Secretary.
Help us here. We have got a number of our national boards who have pre-pandemic looked at combining into a single operation their finance services, their HR services and so on. And there was more work to be done on that. Inevitably, the pandemic paused a great deal of that as we were asking boards to focus on responding to the immediate challenge. But that work was underway. I don't know if Richard wants to say a bit more about that.
Richard McCallum.
Yes, just a couple of things I would add. So that is a pre-pandemic thing that we have always focused on, where there are opportunities to use the NHS estate more effectively to bring, whether it's back office functions together. We will do that, and I think that will continue, and we'll continue to review that as through the pandemic. The Cabinet Secretary gives the example of national health boards. And NSS, in collaboration with the Scottish Ambulance Service and Healthcare Improvement Scotland, have brought together functions at one site at the Gyle. I suppose on the point about home working, yes, I think boards are seeing the benefit of that. So fairly recently, there was the rollout of Office 365 that was done across the health service, and actually having that capacity and having that functionality has really helped to, obviously not all staff are in that position to be able to do that, but it has increased the numbers of staff that can. And I think on the back of that, there is an opportunity for further options for territorial and national boards to look at what opportunities there might be to again look at their estate and use that in a more efficient and effective way. And that's certainly something that we will keep working with them on.
Thank you, convener.
We'll move on now to financial stability issues. Start with David Stewart.
Thank you, Convener, and good afternoon to the Cabinet Secretary and to Mr McCallum. I have a couple of questions around financial stability and sustainability. The Cabinet Secretary is obviously well aware that 4 boards received brokerage in 2019-20, Tayside, Ayrshire and Island, Highland and Borders. I appreciate the Cabinet Secretary doesn't have a crystal ball, but will these 4 boards break even in 3 years' time?
Cabinet Secretary.
So, thanks very much, Mr Stewart. You'll recall that we paused the development of the 3-year financial and savings plans for boards and integration authorities at the onset of the pandemic. We've now returned to these plans and are reviewing what can be delivered this year. The detail of that, again, Mr McCallum knows, so perhaps, Convener, if we pick that up with him now.
Richard McCallum. Richard McCallum.
Sorry, I dropped out again for a second there. I missed Mr Stewart's question, but I think it was on our approach to escalation with 4 boards. So we will continue to work with those.
I fear Mr McCallum's connection is not strong. Perhaps revert to David Stewart and we may be able to bring him in. David Stewart.
The message as well, Convener. Can I raise a more general point to the Cabinet Secretary? I'm genuinely interested, as the Cabinet Secretary knows, about rural areas in particular. And if you look at the 4 boards I've mentioned, obviously apart from Dundee, which is a very strong urban area, all the other boards have a strong rural component. And I know from my experience in Highlands and Islands that there is a number of boards in my patch that have what I would describe as chronic structural financial problems. And the Cabinet Secretary, I think, is aware of what I'm getting at. For example, staff turnover and vacancy levels are high. A couple of examples of consultants on 300,000 a year, locum staff, which was still essential, chronic drug overspend, and management churn. Without naming the individual boards, the Cabinet Secretary knows exactly what I'm talking about. Is this something that the Cabinet Secretary, and when it comes to planning, albeit it was paused during the coronavirus crisis, because this chronic problems do affect the ability of these, by and large, rural boards break even when in 3 years' time?
Cabinet Secretary.
It raises a really important and good point, and there is much in the sentiment that he is expressing that I would not disagree with. And were we not in the middle of a pandemic, I would certainly, I did want to have a better look, as we did the long-term financial planning with our boards, a better look at whether or not there were some of those structural issues that we could address in a different way. I think it is really important that we have a single national health service in Scotland and we don't have individual trusts and so on. But that doesn't discount the fact that individual boards are dealing with very different circumstances in which they are trying to deliver equity of access to healthcare to citizens across the country. So the boards that Mr Stewart is referencing have big geographical challenges. They differ between even those 3 boards, but they are significant. They are greater geographical challenges than, for example, some of our central belt boards have to deal with, but equally they then have high population density and other challenges. So there needs to, I believe, we need to find a way to create stability across all our boards, but with a degree of flexibility that allows us to help them address the particular challenges that they face in those particular circumstances. We've not been able to make significant amount of progress on that at all, for reasons I'm sure Mr Stewart well understands. but I think it is an important and a very important point to log on the record that it is an area that we would want to be able to return to and to begin working through.
Now, my final question, Convener, and thank the Cabinet Secretary. I think it's a very positive tone that she adopted in the answer to my question. I have two elements to my last question. Generally, I suppose my political philosophy will be about decentralisation of healthcare. And the Cabinet Secretary, I think, is well aware of one of my causa liberas, which is the development of a PET scanner within Highland. If I can just give one example to that, Cabinet Secretary, and you're aware of the details, because I put some questions down. In one of the years that I looked at, the cost to Highland for patients going out of region to Aberdeen or Dundee or Glasgow or Edinburgh was 400,000. And whilst I accept that PET scanners are expensive in terms of capital costs, that is a huge annual revenue cost, which is not going to go away. So I suppose partly what I'm suggesting is more decentralisation. I know the Cabinet Secretary's answer on the NRAC formula, which is she doesn't see any change necessary, but does the formula fully reflect the costs incurred by rural health boards?
Cabinet Secretary.
Well, I think in part I've answered that in my answer to your last question, in that I do think we need to find a way to have equity of distribution of funds across health boards, but with a degree of additional flexibility that allows us to recognise the particular challenges that they face. And those challenges are different. As I've said, the challenge of NHS Highland is less about population density. In fact, on the contrary, it is about a dispersed population across a large geographical area. And what that means in terms of the kind of healthcare services that you can provide, the cost of those, the issues around staffing that Mr. Stewart has addressed, and where it is appropriate to centralise the delivery of a service, not necessarily about cost, but oftentimes about clinical safety. We want our clinicians to be able to work with a volume of patients that continues to keep their skill levels high and improve the safety of what they are doing. So inevitably, some services, some healthcare is more central than others. Equally, central belt boards have challenges in terms of population density, high levels of health inequalities and other challenges that their funding has to be able, as far as we can, to allow them to respond to. So the problem I have, as I think we all have with formulas, is that you will never get a formula that works perfectly for everyone. That's not to say that the current formula should never be looked at, but I do think that we need to take on board, if you like, the sentiments behind Mr. Stewart's question, as I said, with which I would not have a great deal of disagreement, and see whether or not in a single structure, which is our NHS, which I passionately believe is one that we should keep, whether or not we can't find better ways to address some of the issues that he has raised.
Very much. I call Brian Biddle.
Thank you, Convener. Cabinet Secretary, in October 2018, the Scottish Government set out its medium-term financial framework for health and social care, in which it identified the need to save 1.7 billion over the period 2016-17, 23-24. Obviously, the Cabinet Secretary has indicated that the pandemic will have an impact on those plans over the period of time that the framework covers. Can I ask initially, Cabinet Secretary, what you would expect to be in a position to provide an update on the medium-term financial framework that will reflect the impacts of the current pandemic?
Cabinet Secretary.
Thank you very much. So up until COVID, we were in line with the trajectory set out in the framework. with both boards and IJBs having secured the necessary level of savings and the portfolio in a balanced position. So we now do intend to review the medium-term financial framework to take account of the impact of COVID, and I undertake to keep the committee informed as we undertake that work and update the framework and make sure that you are well aware of what we're doing and what the outcome of that is.
Okay, thank you. The government are pushing towards or approaching that sort of a regional approach to planning and delivery of services. Can I ask what progress has been made in respect of that, and what savings will be delivered or have been delivered?
Cabinet Secretary.
So again, I may ask Mr. McCallum to assist us here. We were taking that approach. We are in the middle of a pandemic that has significantly changed how the NHS has had to respond, and many of those plans and intentions have been put on pause. We would want to return to that work and to develop it further, but it does depend very much, as with everything else that we've said so far this morning, on how the virus, the suppression of the virus, how successful we are in doing that and in avoiding a significant second wave. So at this point, I'm not sure that I'm particularly able to answer Mr. Whittle's question in detail, but Mr. McCallum may have more that he might want to add to that, provided his connection is working.
Richard McCallum.
Thank you, Convener. I think I would just add two things probably. The first thing is obviously that health boards have, through the pandemic, as the Cabinet Secretary set out, had to set out their own mobilisation plans and remobilisation plans, and we would expect that to continue. Having said that, we are expecting that the boards will look to work together where possible, and to work with one another where there's good grounds to do that. If I can maybe just give two examples. One would be in relation to NHS chief execs. There is still a regional group of chief execs that meet, representation from each of the regions, and one from chief exec from the national boards, and that really is to look at what the approach that we take can be done on a regional basis where there is good grounds to do that in response to COVID. The second thing I would just say, given we're talking about the budget, would just be to highlight that actually one of the things, and it goes back to what Mr. Cameron was asking about earlier in terms of scrutiny, one of the things that we've set in place is that there are regional finance leads as well, looking at spend within regional areas, so that there is peer review of costs that are being incurred through the pandemic. So I think that there is still work going on at a regional level. I think it's been paused as we deal with the pandemic, but it's certainly something as we come to remobilise and renew that I would expect to pick back up in the coming months ahead.
Thank you very much. Conscious of time, colleagues, so I will press on to our last area of integration and simply ask, the Scottish Government's Lessons Learned report highlighted both positives and negatives for integration over the last few months. Can I ask what the Cabinet Secretary's view is of the integration system, and if there are any lessons to be learned that may include, for example, an improvement in structures in place for decision making or the allocation of resources? Cabinet Secretary.
Thank you very much, Convener. It's a very interesting point. One of the areas that was consistently fed back to me by chief officers and others was how in the course of the most challenging months, I suppose, of the pandemic so far in terms of numbers of cases and remobilisation of services and so on. So March, April, May through to June, one of the improvements that they saw was the decentralisation of decision making. So that in terms of an IJB, there were they did not have to, as a chief officer, secure the agreement of a number of committees before they could act. They were simply empowered to take the right decisions using their professional judgment in partnership with their colleagues in local government and the health board in order to make things happen. And I think setting up the PPE distribution hubs, making sure that we were very alert to particular issues on the ground are testimony to how well that works. So one of the areas of continuing discussion then with the chief officers in the IJBs and shortly with the chairs and vice chairs is whether or not the degree of committee structures that they have in place is one that they consider to still be essential. It feels to me that perhaps our IJBs have overdone the replication of committees that already exist in boards and properly for their governance purposes and in local government for their governance purposes. I'm not sure that we need a third tier of all of that. So we'll continue to discuss that with them. We did make sure that in our board mobilisation plans that we expected our boards to produce mobilisation plans that had been developed in partnership with their local integration authorities. And that is what we have seen. To varying degrees of success, as you might expect, but excuse me, we continue to look for that improvement. So I think there are lessons that we can learn to improve the functioning of integration, where the principle of it, I think, remains the correct one.
Thank you very much. Sandra White.
Convener, I think the question you asked and the answers for the Cabinet Secretary covers most of the questions I've been given. There was possibly just one, and I think the Cabinet Secretary answered it in regards to work that is underway to continue the progress of the working together and transparency, which is obviously a recommendation by the ministerial group. I just wondered how far that's going, and that's the only question I wanted to ask, Convener.
Thank you very much. Cabinet Secretary.
So I'm afraid that, like so much of what we've had to say this morning, that work was progressing very well. The ministerial group was paused when the pandemic took off, if you like, and we've now reached agreement, given that with one or two possible exceptions, all the members of that group are now members of the Remobilisation and Recovery Group, including IJB chief officers and representative of the chair and vice chair group are now part of the recovery group. Then that is where that work is being taken forward. But at this point, the focus is on ensuring that remobilisation and recovery is integrated between our boards and social care.
Thank you. Thank you for that.
And finally, Emma Harper.
Thanks, Convener. I am conscious of the time, so I will be really short. That health and social care integration is about shifting the balance of care from hospital to community. Cabinet Secretary, would you expect that a longer term shift in the balance of care because of the coronavirus pandemic?
Cabinet Secretary.
Well, yes, I would. I think that we were, in terms of spend, well on track to shifting to that 50% of spend, as I think I covered in an earlier question. Not only would I expect it, though, to see it in terms of delivery, in my answer to Mr. Adams, in terms of the community hubs and assessment centres, hospital at home, which has long been pioneered very successfully by NHS Lanarkshire, is now being picked up at pace by some of our other boards. So that is absolutely the transfer of formerly hospital-based care to people's homes very effectively, and with significant patient satisfaction and positive outcomes in terms of healthcare for those patients. And there will be other areas of shift. The near me, whilst it was primarily adopted by our GP practices, is also being picked up by many of our hospital-based clinicians in terms of outpatient appointments, again shifting that out of the hospital setting back into the community. So there is a great deal already underway as a consequence of people seeing how they could deliver services in the face of a pandemic, and in doing so finding innovative but very safe and clinically proven ways of delivering healthcare in the community closer to where their patients are.
Emma.
Thank you, Cabinet Secretary. My final question might require a wider answer, but set aside budget, according to the Ministerial Strategic Group, they said that it wasn't working effectively. And obviously, COVID pandemic has affected all budget planning for the future. So does the Cabinet Secretary think that we need to make adjustments to the way set aside is planned? And I'm happy to take a written answer if that would be, beneficial for the time.
Cabinet Secretary.
So I can say very quickly that we had agreed plans with COSLA in terms of making improvements to set aside budget, and also alongside that, this is very important, alongside that, much more effective use of the reserves, some of them considerable reserves that IJBs were holding, so that we could actually make better use of resources overall. Those plans were underway, that agreement had been reached. We then have the COVID pandemic, but there is no disagreement between ourselves and COSLA about the importance of that approach, and as soon as it is possible to pick that back up, then we will do so.
Thank you very much, and thank you to both the Cabinet Secretary and Richard McCullum for your attendance today. That's helpfully answered part of the questions that the committee had. I look forward, Cabinet Secretary, to hearing a bit more detail about this morning's announcement, which of course is welcome, but which is a top-line announcement, I think it's safe to say, and be interesting to see some of the detail behind that as we continue our pre-budget scrutiny. Thank you very much, and we will now move into private session, and we will resume in a couple of minutes on a different platform, but at the moment I now suspend this meeting.